it's my great pleasure to introduce our first speaker. Fola May is really an internationally known expert on colorectal cancer screening. She's an associate professor of medicine at UCLA, and near and dear to my heart, she's associate director of the UCLA Kaiser Permanente Center for Health Equity. Fola, welcome.
Thank you very much for that introduction. Good morning, everyone. It's wonderful to be here. Thank you for the invitation to present this morning. You're going to hear from me twice. So I'm going to start by doing a recap from DDW, and then I'll be back a little bit later to share a little bit about one of my research passions, which is early onset colorectal cancer. So we're just coming off of DDW 2025, and my goal is to recap or to review with you some of the abstracts that were presented in that meeting in San Diego a few weeks ago. Here are my disclosures. So I'm going to present a group of studies that were highlighted at DDW. The first one is on type of submucosal injection for endoscopic resection of large colon polyps. And this is a randomized trial. So the type of, actually, I'm wondering if you can put my slides on the large screen so I can see them a little bit better. Is that possible? It just says no signal. Aha, that's much better for my eyes. Is it okay to proceed or do you need to? Okay, great. So the type of submucosal solution for endoscopic mucosal resection of large colorectal polyps remains a debate. Prior studies have suggested that when we use a viscous solution, it helps with completeness of the resection when we compare that to normal saline. But there is really limited data when we look at larger polyps. So this study aimed to look at the safety and efficacy of using EMR with normal saline compared to EMR with viscous solution for large colorectal polyps. It was a multi-center trial. They included patients with polyps that were 20 millimeters or 2 centimeters or larger, and they were non-pedunculated. And there were two groups. So these polyps were randomized to hot or cold EMR. And then they were also randomized to either submucosal injection with VS or injection with normal saline with a contrast agent. And they did use low-dose epi for all injections. The primary outcome was incidence of severe adverse events at 30 days. And they also wanted to look at some secondary outcomes as well. So in this study, they were able to randomize about 660 patients. They actually saw no difference in severe adverse events between the viscous saline solution group and the normal saline group. Post-procedure bleeding was a little bit more common in the viscous solution group than in the normal saline group. And they also found that when you looked at perforations, there was a reverse but non-significant difference. So there was one perforation in the viscous solution group, and there were 4 in the normal saline group. But this actually didn't meet significance because these numbers were so small in these groups. Polyp recurrence after the procedure was not different between the two groups. In some of the subgroup analyses that they did, they looked at size, the location of the polyp, the morphology or the histology, and that didn't seem to impact the conclusions that they made. And they also found that complete margin treatment reduced recurrence similarly in both groups, as well as that the viscous solution required a less amount of injection volume, which afforded for longer lifting. So these are factors that might help with facilitating the ease of the procedure. Normal saline more often resulted in adequate coloring and facilitated assessment of the resected defect. And the overall assessment or performance of normal saline was often judged by the endoscopist as inadequate or poor compared to the viscous solution. So that was just the endoscopist procedure, seemed to show a slight preference there. So in conclusion, they are stating that the serious adverse events and recurrence rates were similar following EMR of large colon polyps using a viscous solution or normal saline with contrast. So potentially you can pick your favorite method here. However, they do note that the post-procedural bleeding was more frequent in the viscous solution group, that perforation differences might be different, but we need more data and bigger studies there, and that technically there seemed to be some favorability for the viscous solution. The second abstract that I'd like to review for you was titled Prophylactic Colonic Endoscopic Submucosal Dissection, or ESD, Defect Closure, and Post-ESD Outcomes. This as well was a multi-site study. This was actually an international retrospective study. So endoscopic submucosal dissection, or ESD, in the colon does offer many advantages, but it has delayed adverse events, which we know, such as bleeding and perforation. Prophylactic colon ESD defect closure theoretically may reduce some of these adverse events that are associated with ESD and facilitate things like same-day discharge, which we care a lot about in our post-ESD patients. So in this study, they wanted to compare the effect of ESD closure in what they call a closure group to another group that did not receive a closure called the open group. They looked at the effects specifically on delayed adverse events and overnight observation admission rates. Thank you very much. So the methodology here, again, international multi-center retrospective study. They did include mostly US centers, but as you can see, we have international representation. They looked at patients who underwent colon ESD between 2017 and 2024, and they actually excluded all intraprocedural perforations. Delayed adverse events were defined as events within 2 weeks of the procedure, and they looked at the results through univariate and multivariable analysis to assess the effect of the ESD closure on risk of the adverse event and overnight observation. So this study had 543 patients. They looked at the difference between the methodology. So when you looked at complete closure of ESD, a defect, that occurred in about 348 or 64% of the population. And here in this table, they're actually comparing our closure group to our open group. And what they found that when you looked at the closure group, they had more sessile and semi-pedunculated polyps. There was a higher complete resection rate in that group, more high-grade dysplasia, fewer malignant polyps in that group, less fibrosis, and less topical hemostatic gel powder use in that group compared to the open group. They also observed that the DAE event was higher. It was about 8.2% overall. And when they did their univariate analysis, the things that looked to be predictive were piecemeal resection, large polyps, and a larger procedure time. Those all look to be associated with a higher chance of having an adverse event. But when they did the multivariable analysis, which we tend to look at those results a little bit more as more reliable, it was really only procedure time that was different between these two groups. When we looked at a likelihood for overnight observation or hospital admission, there are 54% of patients that were discharged immediately after their ESD, which is fantastic. The question, though, is how can we reduce the number of patients that have to stay overnight? And what they found in this study is that there was a significantly less likelihood that patients would stay overnight if left traction was used, if the polyp was malignant, if it was an open ESD defect, if there was an adverse event, obviously, and less topical hemostatic agent use. So these were things that were made it more likely that a patient would have to stay overnight after the procedure. So in conclusion, in this study, they were able to state that prophylactic closure of colon ESD defects was not associated with a significant reduction in delayed adverse events post-colon ESD. However, they also showed that ESD defect closure was independently associated with a significant reduction of about 12% in overnight observation and hospital admission, which might be important for our hospitals and the facilities that we work in, as well as our patient outcomes. Okay, the next study that I'd like to give an overview from DDW was titled Adverse Events of Cold Snare Compared to Hot Snare and Hot Snare with Ablation Endoscopic Mucosal Resection for Large Colorectal Polyps. So again, revisiting the challenge of patients with large polyps. Here, the authors remind us that EMR techniques for large non-pedunculated polyps, so 20 millimeters or bigger in this study, have expanded since the introduction of cold snare and ablation EMR. They wanted to assess adverse events for newer EMR techniques like these compared to standard hot snare EMR, as all of us are traditionally practicing. This was a secondary analysis of 4 prospective, again, multi-center studies. They looked at consecutive patients that were undergoing EMR from 2019 to 2024. The primary outcome was serious adverse effects or events that occurred in the first group, cold snare EMR, in the second group, hot snare EMR with margin ablation, and then in a third group, they were looking at hot snare EMR with margin ablation and base ablation. So those are the 3 groups that we're comparing in this study. And they're comparing that to your standard hot snare EMR. We had 1,700 patients in this study and 1,890 large polyp resections overall. And just to give a breakdown, it did look like most of those were removed with hot snare with margin ablation at 38%, but they had pretty good distribution across those 4 groups that they wanted to compare. Mean age of the patients in this study was about 65, so a little bit of an older population. The first results that they shared with us that when you looked at severe post-EMR bleeding and post-polypectomy syndrome, it was actually similar in all the groups. So didn't see a difference there. And there was also no increased adverse events when you added margin and base ablation. So found that those approaches were equivalent when looking at those outcomes. Hot snare EMR was associated with higher perforation compared to cold snare EMR, and that was significantly different, and with higher overall bleeding. And this, I think, is important for us to pull away from this abstract knowing. They also showed that hot snare EMR with margin ablation and base ablation, or without the base ablation, but without clipping at all, resulted in higher rates of bleeding. So it's the clipping that's different in that first bullet point there. And that's, again, compared to cold snare EMR. But when you did include the margin and base ablation or margin without base ablation, and you added in the clipping, bleeding was not significantly higher. So another study here showing that there may be a benefit of the clipping in some subpopulation of patients. The risk factors for complications with the newer EMR techniques. So for bleeding, they saw more bleeding in males and people who are on antiplatelets or anticoagulants, large polyps. They saw more bleedings when the polyps were tubular villus or villus histology or high-grade dysplasia, potentially because there's more effort to get out polyps that are looking more concerning to the endoscopist. And then also, when you look at the risk factor of abdominal pain, they found that that was more common in females and when epi was used, interestingly. And then they also found that there was a higher risk for perforation in older patients in the large polyp size, and also when there was the presence of high-grade dysplasia or adenocarcinoma, again, because there might be more aggressive techniques used in those situations. So in this study, they made the conclusion that compared to standard hot snare EMR without ablation, cold snare EMR resulted in less perforation and less bleeding. And I think that bullet is important for us as a take home. They also found that compared to standard hot snare EMR without ablation, hot snare EMR with margin ablation or margin and base ablation did not increase adverse events. And the knowledge of risk factors for adverse events might help you refine how you care for your patients, or at least risk stratify your patients before your procedural planning. So those were the main conclusions there. And I just have one more study that I wanted to highlight from what we saw at DDW this year. This study was titled Assessing Colorectal Cancer Screening Test Preferences by Race, Ethnicity, Health Beliefs and Diverse Underserved Populations. So the authors of this study remind us in their background that the FDA approval of blood tests for average risk individuals highlights its potential to increase screening participation. So a lot of interest right now in what it will look like when we include blood-based screening as a screening option for our patients. And that was really their motivation to examine screening modality preferences, looking at a diverse New York population that had very different demographic and health beliefs. So in this study, they did a survey of adults who were aged 45 to 75. It was primary care clinics. This was in NYU, Brooklyn Hospital. There's a family health centers and also Bellevue, Mount Sinai, and a Queens-based community organization, which is much like an FQHC. They did this survey between October 2023, which is actually before we had the Garden data, and then they extended it through June 2024, which is actually when we had FDA. I don't think. No, actually, we had just, I think, done the FDA review for Garden at that point, but the study had been released about blood-based tests for colorectal cancer screening. And the survey went to everyone, regardless of their prior screening history. So it was a big survey. They had over 1,000 people who completed the survey, and it was quite diverse in representation, as shown here. And interestingly, I think the first result that I wanted to highlight was that the colorectal cancer screening preferences varied a lot by race. So they found that Black individuals who completed the survey, 47% of them preferred colonoscopy. And I think that this potentially is because a lot of the messaging that came out, specifically from the ACG, up and through the last few years, that Black individuals should be screened only with colonoscopic screening. So that might play a role there. But even when we look at among our white individuals in this study, clearly that population had received a lot of messaging and preferred colonoscopy. Hispanic individuals did not have such a strong preference for colonoscopy at 36%. And when we looked at preferences for blood test, pretty high in the South Asian population at 29%. So a third of those individuals said that they would pick a blood test if given an option. And when looking at Asians in general as well, at 38% preferred a blood test as their screening test. They asked, this is just highlighting one of the questions that came out of the survey. And they asked the survey respondents, how would you rank your preference for each cancer screening modality? And the options that they got were blood tests for multiple cancers. So that's like the multi-cancer early detection test, or the MCEDs. We haven't seen those on the market yet, but they are on the way. The second option was colonoscopy. The third option was stool test. And the last option was blood test. And what they found was that when you look at most likely, which are the red bars here, a lot of people said that they would most likely rank a blood test for multiple cancers. So they want to get the biggest bang for their buck, get one blood test me for all the cancers at the same time. And then second to that was actually a blood test for colorectal cancer screening. So this, again, just highlighting that as these tests come into availability, we also need to remember that our patients have already are coming into this kind of new environment with a perception that these tests are viable options for them, and actually maybe even a strong preference. So again, the study is highlighting the rising interest in non-invasive, convenient colorectal cancer screening tests like blood tests, especially in multi-cancer tests as well. And the study also kind of hinted that blood test preference was linked to age over 70. That's another thing they found. Individuals who had not been to college were actually more likely to pick a blood test as their preference, and individuals who smoked actually was the other group that was more likely to pick a blood test. I'm going to stop here, and you'll see more of me in a little bit, but thank you very much.
Thank you, Dr. May, keeping us right on time. Our second speaker this morning, also an expert in colorectal cancer screening, but with really a specific entrance on an emerging field, which is the use of artificial intelligence in many of its forms for colorectal cancer screening. And I'm going to welcome Bill Carnes, Professor of Medicine from the University of California, Irvine. Come on up.
Thank you very much for this invitation. I'm also going to be presenting some abstracts that I found interesting at DDW. Let's figure out how to work this first. This is my disclosure. So the first two are going to be about artificial intelligence. I was involved in the founding of DocBot, which was one of the earliest companies that were involved in development of AI for polyp detection, polyp characterization, et cetera. And as you know, there are a large number of companies now that have marketed FDA-approved polyp detection devices, and now we also have polyp characterization devices. The first one I'm going to talk about is this whole idea of leaving a polyp behind in a way to help reduce costs. And so this study, the whole idea is that in situ diagnosis of polyps less than 5 millimeters in the rectosigmoid may reduce the burden of unnecessary polypectomies by using a leave in situ or leave alone strategy. The aims of this study, this is a randomized controlled study to evaluate the safety and effectiveness of leave in situ strategy when using a combo AI system that not only detects polyps, but also characterizes those polyps. And the primary endpoint was adenoma detection rate. This is a European study, involved 4 centers in Italy and Norway. It included all colon cancer screening, surveillance for polyps, and positive fits in those over age 18. All procedures utilized this device that not only detected, but also characterized the polyps. And then the groups were randomized into either leave in situ if the polyp characterization said that it was hyperplastic and it was less than 5 millimeters, or resect all, which is kind of, at least in the US, considered standard of care, that you're just going to take everything out that you see. And the primary endpoint was non-inferiority of adenoma detection rate. The secondary endpoints were the mean number of polypectomies per patient, the mean adenomas per patient, the true histology rate, which is really kind of the ratio of the number of polypectomies you do, how many, the percentage of the total polypectomies that had an adenoma or a sessile serrated lesion or something that is pre-malignant. They also looked at withdrawal time. A total of 847 patients were in this large study. 57% were female. Mean age was about 61. 417 were randomized into the leave in situ or leave alone strategy, and the 430 were in the basically resect all group. And what they found was that there was no difference in ADR, so the p-value for non-inferiority was highly significant. There was no difference in the adenomas per colonoscopies found. The mean number of polyps per procedure was significantly higher in the resect all, as you would expect. And the percentage of the resections that contained adenomas was significantly higher in the leave in situ group. So they did prove the non-inferiority. There was no loss in terms of the ADR or the APC, and there was a 50% reduction in unnecessary polypectomies. So they say they are the first, and they are the first randomized controlled trial to address the cost-saving strategies based on optical diagnosis with respect to leave alone or leave in situ. The safety and effectiveness of this leave in situ strategy is supported when using this device with a 50% reduction in unnecessary polypectomies and no loss in terms of ADR or the adenomas per colonoscopy. So this suggests that use of a CADX or a polyp characterization module AI may increase the cost effectiveness of screening colonoscopy without jeopardizing safety by using a leave alone strategy. The next AI abstract has to do with the idea that you could use the cloud to help you characterize polyps and identify polyps during colonoscopy. Up till now, we've required purchasing a device in each of our procedure rooms. And the updates can be a little cumbersome. Somebody may have to come over if you're not hooked up to the internet to do those updates. Now with internet being so much faster, where the lag times are getting much, much shorter, that perhaps we can have AI in the cloud and that we don't have to buy a device, we just buy a prescription, and then any room we're in, we can utilize this system. So this was a study called the EAGLE trial, and it was aimed to evaluate the safety and efficacy of a novel cloud-based CAD-E system for improving polyp detection. They don't comment on what the company is or what the device is. There were 4 European countries, 8 centers. This is a parallel group randomized control trial. Colonoscopists were required to have over 1,000 colonoscopies under their belt and an ADR of over 25%. The subjects were either screening colonoscopies or surveillance colonoscopies for history of polyps, and they were over age 40. And they were randomized 1-to-1 to standard colonoscopy versus CAD-E colonoscopy. And the primary endpoints were adenoma per colonoscopy, which was their superiority endpoint. And then their safety endpoint was the positive percent agreement, which is the percent of resections that are confirmed to be adenomas. So it's very similar to the previous study, is what's, of all the resections that are done, how many of them were adenomas. And what they found was that APC was increased significantly with this cloud-based device with a p-value of 0.2 or 0.1. And the endpoint for unnecessary resections was the same for both. So the study demonstrates that a cloud-based CAD-E system is not only feasible, but effective, and it may offer this additional advantage of no local hardware, automated updates, and potentially lower costs. But again, it all depends on how good is your internet, how fast is your internet. The next one I find interesting because it's all about incentives and in terms of how good we are and or how motivated we are to do good quality colonoscopies. And this was a very interesting study from Taiwan. We know that ADR is inversely related to post-colonoscopy colon cancers. And ADR is just, if you find 1, you've got your ADR. If you find 10, you still have that same ADR. So there's no real incentive to take more polyps out once you find the first one. And that's called the one and done. So, I always think we should be leaving no polyp behind. But then the question is, why am I paid the same for taking 1 polyp out, and the next person that comes over has 30 polyps, and I'm spending an hour taking all those out? So in April of 2024, the Taiwan National Health Insurance introduced a reimbursement based on the number of polyps you take out. So the aims of this study were to assess the impact of this reimbursement policy on hospital-level adenoma detection rates over the first 6 months of the policy. Their data was retrieved from the Central Taiwan Colon Cancer Screening Program, which is a program where colonoscopies are done in those who have positive fits. So all of the patients have had positive fits. And then compare the 15 months prior to the policy to the 6-month post-policy, and measure things like adenoma detection rate, adenomas per colonoscopy, adenomas per positive procedure, and advanced adenoma detection rate. And what they found was there was no real difference in cecal intubation rate or ADR, but the number of adenomas per procedure, the adenomas per positive procedure and the advanced adenoma detection rate were all increased post-policy. And these are graphs just showing the dotted line, that's a vertical dotted line shows when the policy was instituted. The graph on the upper left is adenomas per colonoscopy. You can see how it increases after the policy. The one on the bottom is adenomas per positive procedure, and the one on the right is the advanced adenoma detection rate. Unfortunately, they did not address the resection of non-neoplastic polyps or unnecessary polypectomies. So I think this may be my last one. I found this really interested, and I'm sorry, Dr. May, that I stole this one from you. This would have been a good one for you. So Kaiser Norcal and Dr. Corley have had a lot of landmark articles when it comes to colonoscopy quality things. And way back in I think it was 2007 or so, they instituted this systematic outreach and follow-up for colon cancer screening. And we know that prior studies have shown that if you're very systematic about this, that you can reduce racial disparities and increase the uptake of screening. This study really looks at multiple racial groups, and in the Kaiser system, it's a captured group. I'm not sure any other type of institution could really do this. So the aims were to assess the effect of this programmatic screening on screening rate and colon cancer related outcomes across 22 Kaiser Permanente Northern California medical centers. So screening and colon cancer outcomes were assessed annually between 2000 and 2019 in members who were in the screening age population, defined as 50 to 75 at that time. And programmatic screening was introduced in 2006 to 2008. And annually, each of the members of the Kaiser groups were assessed for their up-to-date status. In other words, have they had a colonoscopy within 10 years, a sigmoidoscopy within 5 years, or a FIT test within 1 year? And if they were not up to date, they were mailed a FIT test. And race and ethnicity were ascertained from the health records. Colorectal cancer incidence and mortality rate was assessed through age standardized 2002 US standard population, and follow-up was extended to age 79 to evaluate the effects beyond the cessation of colon cancer screening. The graph on the left shows can't quite read that, but it's the percentage of people who adhered to screening. And you can see that it increased from about 40% before the program started to 80%. So, and each one of the colored lines represents a different racial group, and you can see how nicely clustered together they are. The upper right panel shows the incidence of colorectal cancer among that group, and you can see the decline that we've seen across the nation, actually. But also see how all the racial groups cluster toward the end of this study. And then mortality for colorectal cancer is shown on the bottom slide. So in conclusion, this systematic program for assessing colorectal cancer screening status, accompanied by mail-in FIT test, outreach to those who are not up to date, is associated with a doubling of the screening up-to-date status among all racial groups, a 30% decrease in colorectal cancer incidence, a 50% decrease in colorectal cancer deaths, and a marked drop in the disparities between groups. That's it. Thank you.
Okay, now we're going to get our state-of-the-art talk, and then there will be time for Q&A, as I'm sure there'll be lots of questions about those great abstracts from DDW. So I'm going to welcome back Fola May to the stage. She is going to talk to us about the emerging issue of early onset colorectal cancer, which is a particular research interest of hers. Fola.
Thank you very much for that introduction, and hello again. Okay, so again, I'm honored to give this talk, and I'm excited to present to you on this topic because I think it's one that I'm sure you're all aware of, but that we all need to be increasingly aware of and activists about moving forward, because we have way too many people in this country and now globally dying of colorectal cancer in their 40s and 50s, mostly because they don't know about it, their doctors don't know about it, and there's a lot more that we can do. Again, here are my disclosures. What I'm going to do in the next 20 minutes or so is talk a little bit about national trends in colorectal cancer, including early onset colorectal cancer. I'm going to describe this phenomena of what we are now calling birth cohort colorectal cancer. It's another way that we describe early onset colorectal cancer. We'll talk about possible etiologies of this epidemiologic change that we've seen in the last several years, and then I'll end with some future directions and important points for all of us to take home. So the American Cancer Society every 1 to 2 years puts out a large report on the state of the nation with respects to cancer. And in the most recent report that they put out, they reminded us that we see over 100,000 cases of colon cancer and about 46 or 47,000 cases of rectal cancer every year, recognizing that this is a cancer that affects both men and women, and that among the 4 screenable cancers that are on the rise. So there are really only 4 cancers in the United States that we can screen for that we are continuing to see rising rates. And when you look at people who are age 0 to 54, they are one of these groups. Also, the American Cancer Society let us know earlier this year that of all cancer deaths in people under 50, colorectal cancer is now number 1 in men and number 2 in women. And that's shocking because not too long ago, when I was a medical student and resident, I was really told that this was the disease of people in their 60s, maybe, but mostly 70s and 80s. And when we're training our trainees now, we can't say that. They need to be looking for this disease in people who are in their 40s and their 50s with symptoms. So I'll start by what we all know, which is colorectal cancer screening as a success story. Because we all know that since the mid-1980s, we've seen a decline in the incidence and the mortality of colorectal cancer in the United States. So we all show these beautiful graphs where all the lines are going down over time, whether you're looking at men, women, incidence, or mortality. And this has always been attributed to increase of screening in the United States, to improvements in treatment, although I will say it is not a cancer that we've had huge changes in treatment options. We've had some, but also there's been a reduction in risk factors. For example, there's less smoking in the United States, and that might, which we know is a risk factor for colorectal cancer, that might be contributing to the decline. I love showing this study. It's a study by Ann Zauber, who's a renowned epidemiologist, and her team. It's older data, but it's really demonstrating what we saw in the decline of US mortality from colorectal cancer in the 1970s all the way to 2005. So the black line in this figure is deaths from colorectal cancer in the United States over time. And as you can see, they're going down over time. And the blue bars over that black line are showing the attributable risk reduction by these factors. So the largest bar here is the orange bar, which is the contribution of screening to the declining mortality of colorectal cancer. Again, just showing what great impact that gastroenterologists like you have had on reducing the impact of colorectal cancer in the United States over time. But what I like to remind people recently is that this is a success story with some new challenges. And the biggest new challenge that we're seeing is what we are calling early age onset cases of colorectal cancer. We'll start here by looking at some of the US trends in number of colorectal cancer cases by age and sex in the United States. So I'm going to start actually at the closest part of the slide to me, at individuals aged 0 to 49. And unfortunately, in the last few years, we've actually seen an increase in the number of cases of colorectal cancer in this group over time. Compare that, however, to the middle graph, where we're actually seeing that we're having a plateauing effect. This was a group that we definitely saw a decline in cases previously, but now we're not seeing such convincing data that we're making a dent in the number of cases. And then let's look at the individuals over 65. These are the graphs that we're used to seeing, a decline in cases in colorectal cancer, but that really now is limited to individuals who are over 65. So we're having a plateauing in people who are a little bit younger than that, and then people who are much younger than that, we're seeing a rise. Now, these are American Cancer Society graphs, and I will point out that the y-axes are very different on these graphs. So as you can see, for individuals 0 to 49, it's a much more narrow y-axis, which makes those lines look steeper. But nonetheless, there is a significant difference in the number of cases in young adults over time. When we look at US trends in mortality or deaths from colorectal cancer, we see the same thing. With individuals over 65, so the furthest graph, we see a decrease in mortality over time. Maybe recently there's been some plateauing. For individuals who are aged 50 to 64, definite plateauing in recent years. That's very concerning. And then, unfortunately, most in individuals 0 to 49, we're seeing increasing deaths from colorectal cancer over the last few years. So my colleagues and I like to describe this as the birth cohort effect of early onset colorectal cancer. And if you leave this talk with anything, I'm hopeful that you'll understand a little bit more of this concept if you haven't been introduced to it before. So this graph here, this blue line, is charting our cases of colorectal cancer on the y-axis over birth cohort years. Now, what is a birth cohort? The birth cohort is literally just the year that you were born in. So this is just showing that depending on the year that you were born, whether that was 1945 or 1985, you can look at your risk of getting colorectal cancer, and that risk has changed over time. Birth cohort means that there's a variation in a group of people's experiences and health outcomes that are based on their year of birth. So what we're trying to argue here is that when you look at individuals and the time that they were born in US history, this is actually more predictive of their likelihood of getting and dying of colorectal cancer than anything else. Let's use more illustrative examples. So this is Ronald Reagan. He was born in 1911. So he is of the birth cohort that was born in 1911. And he had colorectal cancer. As we all know, he was one of the first public figures that popularized this disease. He was diagnosed with, when he was diagnosed with colorectal cancer, that birth cohort was actually seeing decreasing rates of colorectal cancer. So when we looked at people who were born in 1911, it actually looked like we were doing better with this disease, that generation was seeing declines. Audrey Hepburn was born in 1929. She also suffered from colorectal cancer. In her birth cohort, you see actually a plateauing of the risk of colorectal cancer. That birth cohort was experiencing decreasing risk, but not to the same extent as the Ronald Reagan birth cohort. Christy Alley, unfortunately, also was diagnosed with colorectal cancer. She was born in 1951. She was born in a birth cohort that at that time, we were actually seeing a complete plateauing of the risk of colorectal cancer. We weren't sure if populations born after that were going to have increasing risk or lower risk. And then Chadwick Boseman, who was born in 1976, actually was born in what we call the highest birth cohort risk cohort. These individuals who are born in the 1970s and beyond actually have the highest rates that we've been seeing of colorectal cancer. And unfortunately, when you look at data looking at millennials are actually have an even higher risk of colorectal cancer than Gen X or baby boomers before them. Some of my colleagues and I looked at national data using the SEER network to look at the proportion of people in each age group, again, unifying with this birth cohort concept, that were diagnosed with colorectal cancer. So we see a notable shift in the age from the year 1992, which is that first wheel of data, to people who were diagnosed with colorectal cancer in 2019. So for example, we're looking now at the maroon piece of the pie, and these are individuals who were 40 to 49 when they were diagnosed with colorectal cancer. They were 5% of cases in 1992. They were 9% of cases in 2019. So that is a pretty significant increase in that short period of time. As well, when you look at individuals who were born between the ages of 50 and 59, they were 12% of the population that had colorectal cancer in 1992, and they're 21% of the population in 2019. We have preliminary data from 2023 that is showing this proportion is only increasing over time. So when we take all these data together and we do large data projections, what we're able to say is that by the year 2030, colorectal cancer will be the leading cause of cancer-related deaths in all young adults, which we define as individuals 20 to 49. So we're already there for young males, and we soon will also be there for young women, making it the most popular cancer for us to diagnose in people in that age group, unfortunately. So we know that these epidemiologic changes are really what fueled the United States Preventive Task Force to make new recommendations for colorectal cancer screening in the year 2021. And this was the first time that they said maybe we should be screening earlier based on modeling data recommended that we started screening at age 45. And because they said that this was a grade B recommendation, that's mandated to be covered by insurance. Anything, at least for now, as long as the USPSTF is still existing, and right now there's a big Supreme Court case to understand whether it will continue to exist. But for now, anything that the U.S. Preventive Task Force says is grade A or B recommendation has to be covered by insurance. And that's why all Americans get free coverage for colorectal cancer screening once they turn 45. And we'll see actually any day now what the Supreme Court rules about the validity of the USPSTF and their recommendations like these. So many people on buses, trains, planes, wherever I go, ask me, why is this happening? Why is it that a disease that really only affected people in their 80s and 70s is now affecting people in their 30s and 40s? And the reality is we don't know. It is likely a combination of factors, and we're very convinced at this point that it is largely environmental. But what I can share with you is what our colleagues in the field have found over the last few years. We have found that there are many behavioral and health factors that might be playing a role. There's a very strong evidence for some of the things listed on the left column here that, for example, tobacco we know is highly related to early onset. Alcohol, unfortunately, and not so much small amounts of alcohol, but people who regularly use alcohol. And there's a lot of really interesting data about binge alcohol use and cancer risk, not just colon cancer risk, but many cancers. So of course, many of those things are modifiable, which is good news, because if we can educate people on how to live healthier, then maybe we'll see changes in these trends. We know that there's a lot of concern about red meat, hyperlipidemia, sedentary lifestyle, and TV viewing. Those have some evidence, but not as strongly as the factors in the first column. And then on the other hand, there are things that we think are protective. So while we're telling our patients to cut back in certain lifestyle factors, we can tell them to increase things like physical activity, safe NSAID and aspirin use, fiber in their diet, things like that. So these are some of the things we know are related. A lot of emerging data on environmental exposures that maybe we have less control over. So synthetic dyes, things that we use to preserve our food in the United States and globally, MSG, PFAS. There's a lot of attention to PFAS right now. And interestingly, we think that it's not just having exposure to these things when you're an adult, that potentially it's having these exposures when you're young. So maybe even when you're in the womb, because there are some data that antibiotic use by a pregnant mother might affect the fetus's chance of getting colorectal cancer when the fetus is 40 or 50. One study that shows a relationship with cesarean section and risk of colorectal cancer in the child, and also a few studies now that show that when a mother has obesity during pregnancy, the child is more likely to develop colorectal cancer. So these are some of the things that we have the strongest data for. And overall, though, what we've learned, though, is there's no smoking gun. It's not like lung cancer where we can point to one thing like tobacco use to explain 80% of cases. Here, it's probably a combination of things. there's a lot of questions as well as where do genetics play a role? So we know that 30% of people with colorectal cancer have a family history. But that just leaves a lot of, that leaves 70% of cases that don't have a family history. And the overwhelming studies that we have right now are really showing that maybe it's the interaction between your genetics and your environmental exposures, somatic alterations, all of that together that is accounting for colorectal cancer risk. And this is what we call the exposome. The exposome is this concept that if you could measure all the exposures that you've had in a lifetime, that is your exposome. That is the environment of risk that you have been living in. And those exposures start from the time you were conceived through the time that you die. And these include internal and external insults from environmental exposures, occupational exposure. These things can interact with your genome. They can lead to somatic changes, and they can determine your health outcomes. And the other really important thing about exposome is that I might have an exposome that's very similar to one of you in the audience, but because my genetic background is different, I might actually not have the same health outcomes as you. So it's not just the exposome alone, it's that very unique interaction between the exposome and your genome that's predicting your likelihood of getting an early onset cancer like colorectal cancer. It's really fascinating. I think also what's really interesting is that this is happening everywhere. And when you look at parts of the world that are globalized or westernized, as we say, more modern, we're seeing that this rise in early onset colorectal cancer is happening in those regions of the world as well. So this figure here, each line is representing a region of the world. We're seeing in East Asia, we're seeing in Latin America. In addition, we're also seeing in parts of Europe, particularly in Australia as well, we're seeing this new emergence of cases in people who are young. Another line of research that is really popular right now is looking at the influence of life course exposures on the gut microbiome and why that might impact colorectal cancer risk when you are a young individual. And there are prior studies that really emphasize a role of this gene environment interaction throughout the life course, potentially through exposures on the gut microbiota composition. So it might be that all of these exposures that we accrue over a lifetime are acting through microbiome to increase our risk for colorectal cancer. And that's a very hot topic for research right now as we continue to try to understand what's causing this epidemiology. In my last few slides, I wanted to highlight a few things that I think are very important for all of us in GI to be aware of coming up in the next few years. So first of all is that I do think it is going to be largely our responsibility to fight back against this rising epidemic of early onset colorectal cancer. We need to help increase awareness, not among just our patients, but also among our colleagues. I actually was at a survivor event last night in Hollywood where survivors shared stories about how their symptoms were ignored, sometimes for 1 to 5 years. Their rectal bleeding was passed off as hemorrhoids, or their constipation was passed off as normal for years, and then were diagnosed with stage 3 or 4 colorectal cancer. So it's really on us to take these symptoms seriously. We can no longer say that this is a disease of people in their 70s and 80s, and we need to consider diagnostic workup for people maybe we weren't considering before, including people in their 30s and 40s. And that's why I drive my fellows a little bit crazy in our VA clinic, because I'm lecturing to them all the time that even though it's a 40-year-old men, that's actually the group that we're seeing the most rectal cancer right now. So we're actually going to go ahead and pursue a colonoscopy for many of those patients if the symptoms are concerning and we can't find another cause. We also need to identify the best screening recruitment strategies, particularly for young adults. We've been doing research at UCLA trying to understand how we can recruit people who are in that 45 to 54 age group. That's the group that tends to put screening off, and they put it off and they put it off, and then suddenly they're presenting with a cancer. So we're actually pretty good in this country at screening people who are 60. By that point, people have gotten the message, they've had a colonoscopy, but it's those people who are entering screening eligibility, 45 to 54, where we're seeing very low screening rates. And I do think that we can make a larger dent in that group as GIs and educating about the importance of starting screening on time. We also need more large prospective studies to understand the associations between novel genetic and epidemiologic risk exposures and early onset colorectal cancer. And these studies need to be throughout the lifespan. What these studies would involve would be following people from birth until their 40s, 50s, understanding their exposome, their lifetime exposures, and then also understanding their cancer risk. This would help also not only for colorectal cancer, but for other cancers that we're seeing early onset. And we're seeing early onset in about 8 cancers right now. So it includes breast cancer in women, prostate cancer in men. We're also seeing a rise in early gyn cancers in women, some subgroups of women. So there's many cancers that I think we would learn from for these types of studies. And we also need better research to understand the mechanisms for early onset cancers. The last thing I wanted to talk about briefly is the emergence of non-invasive screening tests, which we think might help play a role in our ability to screen more people for this disease. And I like to think of these tests as late phase tests and early phase tests. There are many different tests that are being studied right now, and some of them are just about to be on the market, and other of them are very early in their investigation. So this is a list of some of the emerging non-invasive strategies. These are not yet recommended for first-line average risk, although some of the guidelines are starting to come out now acknowledging tests like the blood test. We have not had United States Preventive Service Task Force say that we can use any of these tests yet. So I just want to say that. But we're looking at things like microRNA in the stool. We're also looking at, instead of DNA, like fit DNA, we're looking at fit RNA in the stool. Cologuard 2.0, everyone's familiar with Cologuard 1.0, which was a fit DNA test. That's about 8% of, I think it's 6 to 8% of screening in the United States. Right now, they have a new version of Cologuard that they're slowly going to start releasing that you'll be seeing and make it made available to your patients that we're calling version 2 or Cologuard Plus, as Exact Sciences is calling it. We also have stool microbiome assays that many labs across the country are trying to combine the concept of a FIT test plus a DNA test plus a microbiome test into one stool test that will screen for colorectal cancer. Of course, cell-free DNA, which is our first FDA-approved blood-based test for colorectal cancer screening. That comes from Guardant. And then also, as I mentioned in my prior presentation, we're going to have these early detection, multi-cancer early detection tests, or MCED tests. So many things that you're going to be hearing about in the next few years as options for you and your patients. There's a lot of, I think, interest right now in cell-free DNA blood-based testing for colorectal cancer screening. This is the New England Journal article that presented the Guardant data. This test is a blood test. So this is the concept that when you send your patient for their annual CBC or their annual H1 hemoglobin A1C, that you can also just check a box to get them screened for colorectal cancer screening, which would be very convenient for our patients, right? And I think that's why, as I mentioned in that last abstract in my last presentation, there's a lot of excitement for these tests. I do like to remind people that this is an incredible moment in science that we are getting these convenient tests, but we also have to remember that these tests are working a little bit different. When we look at something like a colonoscopy, our goal is to remove polyps and to find cancer. So it's both preventive and early detection. These tests are a little bit different in that they're mostly working towards early detection. They will find the sensitivity for colorectal cancer is about 83%. But when you look at advanced precancerous lesions, so advanced adenomas or SSL, so sessile serrated polyps, they're only going to find about 13%. So we just have to remember that we are forfeiting a little bit of that ability to prevent colorectal cancer with these tests. And I think this is the trade-off that we're going to have to consider is here we see that there are pros and cons. Like, should we, people ask me, should we just give everyone a blood test? Or on the other side of that, should we just give everyone a colonoscopy? I think when we consider these different screening tests, we just have to think about the intended and unintended consequences. So we talk a lot about a substitution effect. What happens if people who were previously getting colonoscopies suddenly switch to blood-based screening? And in those people who we were doing a really good job of getting polyps out and preventing disease, maybe when we switch to blood-based screening, we won't have that much of a benefit. And that's one thing that people are a little bit concerned about because you would have less cancer detection. You'd have less detection of advanced adenomas and SSPs. And you really would need a very aggressive system in the United States to make sure that everyone who had an abnormal blood test got a colonoscopy. And right now, we're not good at that, at getting follow-up colonoscopies when people have abnormal stool-based tests or abnormal Cologuards. So those are things that people are concerned about. But then on the other side of that, there's this amazing potential for recruiting people who've never been screened to the screening pool if we have a blood test that they can easily consent to with even their primary care provider. That potentially can result in higher screening rates. We know that more choice is good for patients, very easily performed, and patients think blood tests are a lot less invasive than a colonoscopy. So these are all the things that we have to keep in mind. My approach has been, I educate my patients about the pros and cons. Everyone's going to be a little different. Some patients really care about that prevention and they're going to stick with the colonoscopy. Some patients say, oh, well, if there's a blood test, I think I'm kind of low risk. I might do that and for a few years and get a colonoscopy later. Everyone's going to take that information differently and decide what's best for them. The most important thing is that they understand that these tests are working a little bit differently. Okay, hopefully I'm keeping us on time still. I'm going to wrap up. So in conclusion, what I hope you walk away with is understanding a little bit more about the recent changes in the epidemiology of colorectal cancer, and potentially even understand a little bit more about what we call this birth cohort effect. So instead of focusing on the age of diagnosis, and a lot of research right now, we're going to be focused on what year were you born and how is that related to your risk. There are several clues that suggest that there are likely many factors that play a role in the shifting epidemiology rather than a single etiology. There's no smoking gun for, say, like we have tobacco use for lung cancer. It's probably a lifetime or early life exposure of a combination of environmental exposures. Environmental exposures during the life course that are important may include some of these metabolic factors we talked about, dietary factors, alcohol, inactivity, and even exposures in utero and or early life, which I think is fascinating research that we're seeing there. And there are several new screening modalities, as we've just talked about, that are entering practice. And my hope is that you learn about these tests so that you can educate your patients about the pros and cons and the intended and unintended consequences and make the best decisions for you and your patients. I think that is the end of my presentation. Thank you very much.
Okay, Bill, maybe I could have you come back up. I think we've got lots of time for questions. Before Dr. Jensen leaves, I just will ask one to start. So it's interesting to see that in the comparison of lifting agents, viscous versus saline, that the bleeding risk was higher in the viscous solution. And I wonder if you speculate on mechanism. Is that because you're compressing the vessel that's there and you don't see acute bleeding and therefore maybe you don't treat it? Well, Dean just left, but I was going to ask him, obviously Doppler, through the scope Doppler ultrasound can be used in a post-polypectomy bed, but if there's viscous solution that's still there, if you're doing it acutely, it's potential. We've seen that, you do compress the vessel and you maybe don't treat it. So thoughts about that?
Thank you.
Just...
Can you hear me now? Okay. Thank you for that question. And, when looking at that, the numbers are so small sometimes in these first studies that I try not to hang on it too much, but I did see that difference. And I did also wonder if it was a technique difference or compression on the vessels you mentioned. I actually did think about, when we find these differences, you wonder what the mechanisms are, and using something like ultrasound might give us more insight. And I do think that a lot of times, the bleeding risk might be more related to how aggressive we are with the technique, which is related to how big or scary the polyp might look to us. So I think there's a lot to sort out there, and I wouldn't hang my hat on it, but it's something that probably needs to be investigated in more studies.
Thank you. Dr. Menz.
Several questions for both Dr. May and also for Dr. Carnes. Dr. May, have you seen the recent paper out of Nature looking at UCSDs and identifying colobactin?
Yeah.
I think that's going to be really interesting to look at early onset DNA damage induced by this E. coli toxin produced. That was the first comment. But the thing I wondered about, thinking about Sid Winnauer's retrospective look at the National Colon Polyp Studies, we started that in the 1990s. And I think around 2010, he looked at the fact that doing preventative colonoscopies dropped the death rate from CRC from 6% down to 3%. And if we look at where your data showed that we were only about 1% for the cohort of people born in 1950, I'm having a hard time reconciling that 6% that Sid was able to quote, and I can't remember all of what he did to get that baseline rate of death rate of 6% for CRC, and then showing that we had the death reduction due to colonoscopy to your initial onset. That was my thought for you. And one for Dr. Carnes, and that is, I think most of those studies were looking at very small polyps where we would ordinarily, at least I do clinically, ignore those, particularly in the sigmoid colon, the rectosigmoid colon. We knew that that was a non-productive reason to take FRBs. You know what FRBs are? Financially remunerative biopsies. And I really came down on colleagues that I thought were doing that and still see it done today.
Thank you for those questions. I mean, hopefully I remember them. The first one, the colobactin. Yes, I did see that study. This is reference to a study that was recently released in Nature that showed a high prevalence of a specific bacteria in the colon in individuals with early onset colorectal cancer or young onset colorectal cancer in one cohort. And I think it generated like more text messages from my girlfriends than like any other study I've ever seen, because people were asking me, how do I avoid this bacteria? I think it's fascinating, but I actually think it points more to the point that I was making, that it's probably a combination of factors, because that bacterium does not explain all cases. It definitely points to the fact that there's probably a role of the microbiome here, and there's probably imbalances in the microbiome that shift you more likely to acquiring or developing adenomas and then cancers in some people, right? So it's more about your specific group of exposures, and particularly this bacterium in some people. But again, it's great because it's one piece in this large story that we're trying to tell. You referenced Sid Winnauer's paper about the mortality reduction. I want to make sure that I understand the question a little bit better before I try to answer that one.
What I was referring to, if I looked at all the data that you were showing for the risk factor, like born in 1950, I believe that showed on your projected chart 1% or maybe 1.5%. And yet, how did he get, or how did she get from 6% down to 1%, if you will, using that data?
Oh, okay.
And it's just because you understand the epidemiology and I don't. That's why I'm asking.
Yeah. So no, I understand now. So in the Winnauer paper, that is looking at a relative risk reduction over time. So it's looking at a risk at one time point and what percentage points you've reduced that risk over time. And then the graph that I'm showing is your absolute risk of developing the disease depending on the year you were born. So it's just a different percentile does that make sense? So if you were born, actually, it's right around 1950s, 1960s that we see this shift where your risk is low in cohorts that were born before the 1950s. That's the Reagans and Hepburns. And then late 1950s, anyone born in cohorts after late 1950s is where that risk goes up. Is that more clear? Okay. Now I've completely forgot the
And then
third
the
question.
last one was, I think, more for Dr. Carnes, which
Okay.
was about
Yeah,
leaving.
and I
just the
wanted
clinical
to
practice
just
of
add,
hyperplastic appearing polyps, leaving them inside too.
Just wanted to add my 2 cents to the question related to the reduction in mortality in colon cancer shown in the New England Journal article in the follow-up of the National Polyp Study. That was a comparison of SEER data versus those who had colonoscopies. So we don't know for sure what percentage of the SEER population had colonoscopies. So, it might be 50%. So we still saw a 50% reduction in colon cancer mortality, but it was probably higher than that.
Yeah,
Um,
thank you.
Yeah.
But did you answer the last?
No, I'm still struggling to understand what the question
I
was
think it was
related,
just saying
but this was diminutive polyps in the rectosigmoid.
Well,
And
I believe that the study was looking at 5 millimeter or less polyps and using optical, data to try and decide which one is malignant or which one is pre-malignant
Yeah.
versus not. And my point is, who cares at 5 millimeters? And so I'm not trying, that was my mean comment about FRBs. But no, I would agree that beyond that, this is very useful information to have optically in front of me to know what to go for.
Yeah. So if the accuracy is good enough, and with greater than 95% probability that this little 5 millimeter polyp is hyperplastic based on the performance of an AI, then, the PV protocol would say, go ahead, leave it alone.
Yeah.
In the US, can we do that? What if there's a colorectal cancer found, a post-colonoscopy rectal cancer found, and you practiced in a way where you left things behind? What's that going to mean legally?
Yeah, exactly. But I do think about, just tagging onto this, I do think about countries where there are fewer resources, and tools like that could be extraordinarily helpful because they don't need to process, they don't need to send that off to pathology to be read. So I think there could be potentials in other parts of the world as well.
And potential billions in savings in
Yeah.
terms of pathology costs.
maybe microphone 1
Yeah.
here.
I have a question for Dr. Carnes related to that subject. The European study, based on optical study, small polyps, if it's optically not pre-malignant, leave it alone, right? So that will lead to cost saving. And the Taiwan study is the opposite. Before, whether how many polyps you remove, it didn't matter. But once you have an incentive to remove all polyps, they were detecting more adenomas.
Yeah, that was
They're
interesting,
pointing
wasn't it?
to different directions. So what are we going to do?
Yeah.
Do we still remove all polyps when they're suspicious? Okay. And I have an interesting observation, the epidemiology. 30 years ago in Japan, colon cancer was on the top 10 of cancer deaths in Japan. More recently, last 5 years, it's number 3. So what happened? Okay. And also, so there's a bad joke. It says Japan exports cars. And with the food, American food, all over the place in Japan, colon cancer incidence has increased. So America exports colon cancer.
There you go.
I think it's true.
Wonder if the tariffs will take care of that.
So that's a bad joke. And another observation is that Chinese men 30 years ago had very few colon cancer. Once they come to the US, their colon cancer rate is higher than white average Americans.
Yeah.
And mostly Chinese men, not Chinese women. That means Chinese men are so, what do you call it, careless with what they eat. They didn't eat enough meat. They, gouging everything, all the meat they can get in America.
Mhm.
So there's a tremendous change in diet when they come to America. And their colon cancer rates exceeds white Americans.
Thank you for that. Dr.
Mhm.
Khalid?
Abdul Khalek, Sacramento. We in clinical practice, we get these patients like you guys mentioned with rectal bleed, young people, and it sounds like hemorrhoids, many times, but there have been patients that we have scoped and they have had large polyps in their rectum or sigmoid colon or wherever. I guess the question is, when if there are some data now that you can actually extend colonoscopies like beyond 10 years in patients who are average risk and they don't have anything in their index colonoscopies, do you think we should start screening colonoscopies at 40 and then do the next one 15 years later or something like that?
Do you want me to start?
Go ahead.
Okay. I think this is something that everyone's very interested in. And again, for the audience, the question is, should we be doing this earlier? If people are getting this disease and dying from it in their 40s, why are we starting at 45? So those recommendations are based off of two very large modeling studies that are conducted every year by the Sysnet group. And when they conduct these modeling studies, they're looking at the likelihood of developing cancer while varying gender, age, race, ethnicity. And every time they run those models, from a population health standpoint, 45 won. They will rerun those models again, probably in the next year or two, again, depending on whether the USPSTF is still around after the Supreme Court decision, and we'll see what the models say. But a lot of people are thinking, maybe it'll be 43 or maybe it'll be 42. People always ask me, why is it always 5-year increments? What's it about 45 and 50? Yeah. So I think it's up in the air whether that will change. I know when you talk to survivors and their family members, there actually is a lot of anger in that community that we don't screen earlier, that we don't educate earlier. Because if my wife, friend, brother, sister knew about this disease when they were 43, they wouldn't have passed away from it at 44, below the screening age. All I can say right now is that this is why we have to be very cognizant of this increased risk in younger people under 45, and why we cannot ignore their symptoms. And I think even sometimes maybe even escalate to a colonoscopy earlier than we would have historically, because we aren't screening that group, and it's the group that's having increased incidence.
What's your opinion when you have a young person who presents with bright red blood per rectum? It's more and more we're saying straight to colonoscopy, but if it's bright red, what about just doing an office FlexSig?
Yeah, and I know a lot of people will start, if some places are set up for it. Mm-hmm. Increasingly, sometimes FlexSig is harder, than. But I think that's a reasonable approach. I have a lot of colleagues in our VA. Sometimes it's easier just to do a colonoscopy, but in some settings it might be appropriate to start with the FlexSig. If you see a large polyp or hemorrhoid that explains the bleeding, then you're done. If you see nothing, then tell the patient to come back for a full colonoscopy. And I've definitely seen that approach. The problem is that we've just never formally studied any of these approaches. So right. A lot of people, including Samir Gupta, who's at UCSD, we're writing a big grant right now to look exactly at that, is what can our diagnostic approaches be in people under 45 so that we're not missing cancers?
Microphone one.
Hi, Rob Kung from Kaiser Irvine. Thank you for your talks. 2 questions. The first one is pretty short. Nanoplastics and microplastics. I didn't see that on the list of environmental factors, but obviously there's been a lot of buzz around that. So just your thoughts, or if you've seen data about that. The second has to do with, I was a fellow at UCSD, and Samir Gupta, I remember one time said, when the cost of doing genetic testing gets low enough, we should just be doing, mass genetic-based testing for screening for the whole population. And I don't know if that's happened yet, at least in the Kaiser system, it hasn't, because we're restricted. But, patients are getting like 23andMe tests done, and I had one recently come in with positive MU-TYH. So I'm thinking like, wow, yeah, she's 21 years old, and they're finding it, through these commercially based testing that wasn't meant for that, but they're showing up with that. So I just wonder, at what point can we start to implement that? And I know it's more a cost issue than anything still, but anyway, just kind of your thoughts about that.
Personally, I think it's quite a good idea, particularly considering that 1 in 270 people have Lynch syndrome, and probably only 20% of them ever know that they have that condition, where their rates of colorectal cancer are going to be 50 to 80%.
Yeah, and I agree. I mean, I think we're already there. I think it's inevitable. I just don't know if formally it will be recommended. I think the challenge is that there are so many genetic mutations that we don't know what to do about. I mean, we've all had these patients come in with these long reports on either their microbiome or their 23andMe, and they're like, explain this gene. Yeah. And it's like, I don't know what that means. I don't know what your actual risk is, and I don't know if that warrants a colonoscopy. I don't know if your insurance is going to cover a colonoscopy for this. So I think we do need to do a much better job at the diagnostic cascade of what we do once those reports come out, before we just start testing everybody. I think that would be my one kind of piece of advice there. Microplastics, yes. I I think increasingly we are learning that the way that we prepare, store, preserve food and beverages in this country is probably a big factor in many of these early onset malignancies, not just colon.
And I think with regard to mass screening, if you're doing that kind of thing, there are risks to doing that. There'll be risks to using AI and radiology and finding nothings, or the executives who are going for their annual total body MRI. And what do you do with the results? What does it cost on a population basis? And counter to that, I'd say to me, the biggest victory lap that I saw at DDW was presented by T.R. Levin. Bill went over it, the Corley study, which shows that a programmatic approach with FIT, which costs less than $1, done on a mailed basis. And a lot of people, I don't know the percentage for TPMG, I kind of know the percentage for SPMG. A lot of people don't come in necessarily right away for a positive FIT test, which is kind of a tragedy. But eventually, a lot of those people do get a colonoscopy. And I think that's part of the reason it works, because there is kind of a degradation in compliance with FIT that we've seen in many studies. But I kind of wonder if either of you were the health czar for something like Kaiser or the VA. I know the VA is trying home fit, especially in the 40 to 50-year-old group. Would you do a FIT test with a lower threshold because you really care about getting the cancers and you're okay with a few more false positives? Would you do a cell-free DNA test, which costs a lot of money? Would you think about Scsg? Because most of them, there's a shift towards the distal colon and rectum. It's kind of a different, people have said it's a different organ than the rest of the colon. So what are your thoughts?
I love questions that start with, if you ruled the world. I think about this all the time, and I know exactly what I would do. I think the first thing that needs to happen for everyone is a risk assessment. So would get into, what's your family history? Do you have Lynch syndrome? Can we sort out who definitively needs a colonoscopy?
I mean,
So
they come
separate
into
out.
their primary care doctor, which a lot of them don't.
They don't have time.
Yeah.
Their primary care doctors are charged with assessing 26 preventive health measures for an average 55-year-old adult, So we got to find a way to do risk assessment earlier and better. And we got to separate out this 22 to 25% of people who just need to go to colonoscopy. Like, that's number one for me. After that, I think it depends on your resources. So if I had a magical healthcare system where everybody could have a colonoscopy safely and it could be done in a reasonable amount of time, then yes, I personally would love for everyone to have at least one colonoscopy during their life. I don't know if that needs to be their first screening test, but at some point, there's some people who've done really creative research where they've done FIT for 10 years and then a colonoscopy, or with a reverse, right?
Depends on their cohort.
Exactly. So I think that's fascinating as well. And then I think the third piece of it has to be that you're going to always have this 20% of the population that refuses everything, right? Like, I'm not getting a colonoscopy. You sent me 50 FIT kits. I'm not going to complete them. That's the group that I would just give the blood test to. That's how I would set it up.
Fair enough.
I want to hear what you have to say.
Yeah, I would wonder though, how are they going to respond to their positive blood test?
Oh, we're gonna tie them down.
Okay, last question.
Two things. Number one, comment about Scsg. Are you prepared to process your Scsg in the office like you do in the hospital and keep every agency that looks over you? That's why we gave it up in the office, because we couldn't do it to the standards that are required today. The big question that I have is cold snare on large polyps, and we know that the recurrence rate is 20-25%. And if we then invoke edge ablation, does that increase the risk of perforation by any amount, lots, and does it decrease enough the amount of recurrence? I believe it does, but that's a whole different type of scenario that we haven't addressed this morning. Cold snare, large polyp, and then edge ablation to reduce.
Yeah, and I think in that study, the suggestion from that study was that there wouldn't be a difference compared to hot snare.
They didn't really record large polyps and recurrence rates.
Oh, for recurrence.
That's
Yeah.
the whole point behind edge ablation and why.
No, I thought, yeah. I think that's an area that there's no data that we could actually use to direct our current practice.
Okay, thank you for a great session.
Yeah.
Okay, everybody, I think we're going to get started with the rest of the morning sessions. Really exciting session once again. We've tried to get this next speaker for a few years, and we finally got a weekend that works for her. This is Scsg Shah, who's a professor of clinical medicine at UCSD. And if you read any kind of probably original work, but definitely any guideline in the US, and there are many now, which she'll go over today, about gastric premalignant conditions, screening, surveillance, et cetera, a pretty good chance that Scsg is going to be one of the lead authors, really a world expert, and we're lucky to have her today to talk about this very important problem.
Wonderful. Thank you so much for the introduction. I'm so glad that I can finally make it here, just a little bit north than home. So this is great. But thank you again for the introduction to speak on the upper GI abstracts, and to kind of stay in theme. The ones that I selected were what I considered potentially practice changing for stomach and esophageal cancer prevention. These are my disclosures, none of which are relevant to this talk. And so this was, so the first abstract that I wanted to highlight was an oral abstract, the optimal age of H. pylori screen and treat for gastric cancer prevention in the United States. And just by way of background for the relevance of this abstract is that it is well established through randomized control clinical trials, nearly all of which are from Asian countries, that the greatest benefit of H. pylori eradication is before the development of gastric premalignant changes. But we need to also balance this, eradicating H. pylori with antibiotic exposure early in life, and also, other unintended downstream consequences. So, not too early, but not too late. And kind of understanding the importance of this timing of H. pylori eradication for gastric cancer prevention, the Type A Global Consensus, the first iteration, and then most recently in our second iteration, we've suggested that the optimal age to screen and eradicate H. pylori for the purpose of gastric cancer prevention is 20 to 40 years old. So this is for Asian populations. But most recently, which we'll go through in my next talk, that it's exciting that now there is alignment from the US guidelines, so the 2024 ACG guidelines and 2025 AGA clinical practice update, that both advise testing and eradicating H. pylori for the purpose of gastric cancer prevention, but they don't actually say at what age we should be doing this, because these are mostly asymptomatic patients. So again, limited data. And so that's why this group aimed to determine the optimal age for H. pylori screen and treat in the United States for subgroups of varying gastric cancer risk levels. And this is this group, they really do specialize in modeling studies, and they have developed their own model that they call MISCAN, so the microsimulation analysis screening model. And they've calibrated this specifically to US data, so using SEER gastric cancer incidence data, precursor prevalence data, and H. pylori prevalence from NHANES and other literature. And they evaluated one-time H. pylori screen and treat scenarios between the ages of 20 to 65 and assumed a test sensitivity about 92% and eradication rate of about 80% just based on clinical data. And what they looked at was modeling two different scenarios. So if H. pylori eradication occurred before gastric cancer precursor development, what was the impact on gastric cancer? And then if eradication occurred after precursor lesion development. And these were the results. So H. pylori eradication could reduce cumulative gastric cancer incidence by 37 to 43% when performed at the age of 20. And this is compared to only a reduction of 3 to 5% when performed at age 65. And this was they only looked at two racial categories, so white and black. And so again, 37 to 43% versus 3 to 5% when performed after age 65. Number needed to treat and number needed to screen remained stable for testing between 20 to 35, but increased rapidly when testing occurred at age 40 or older. And just to kind of put some numbers to that, so for the number needed to treat to prevent one gastric cancer ranged from 261 among Black males, which is one of the highest risk groups, to 1,060 among white females when testing occurred at age 20. And so here they concluded that H. pylori screen and treat demonstrated optimal efficacy when conducted before age 40 years old. And this is in alignment with the Type A global consensus that is based on clinical trial data. And so we can maybe talk about this in the question and answer, that this is an important study. It's a modeling study, but then there's also practical implications when we think about implementation and participation, especially in this age 20 to 40-year-old group, which we discussed in the last session is hard to really engage in care, cost considerations, and antibiotic resistance considerations. So the next abstract that I wanted to highlight was a poster presentation, the prevalence of H. pylori infection among asymptomatic multi-ethnic U.S. population, a gastric cancer screening study, and this is from the Baylor group. The reason I liked this study is, if you'll remember from the previous study that I just presented, the literature estimates that they used for their model was from NHANES data, and that data, the NHANES study is actually essentially our only population-based sample for H. pylori prevalence in the US, and that's about 2 to 3 decades old. So this is now one of the newer quote-unquote population-based studies. So this group, so here the objective was to determine population-based prevalence of H. pylori among asymptomatic individuals who underwent H. pylori testing as part of a gastric cancer screening study. And methods that they used are outlined here, that it was a cross-sectional study, mostly of a largely underserved immigrant and minority patient population receiving their primary medical care in an urban safety net healthcare system in Houston, Texas. So again, when we're thinking about generalizability, this is the population that they looked at. Individuals aged 30 to 65 years old. They used serologic-based testing and then calculated the prevalence and 95% confidence intervals overall, and then also looked at subgroups based on race, ethnicity, and also some age categories. And so the results are what you can see here. So it was actually a pretty large sample, over 1,000 individuals. And participants in this study were a mean age of 47 and a half years, 70% female, and mostly a Hispanic population. But in this group, again, asymptomatic individuals, H. pylori prevalence was similar across age groups, and highest among males was about 70%, females 62%, and the overall group was 64%. Prevalence of H. pylori was highest for Hispanics, which we could expect, and lowest for non-Hispanic whites, but that was still about 45%. And so here in this study, they concluded that the prevalence of H. pylori in this urban safety net population among asymptomatic individuals was about 2/3 and was over 40% in all subgroups. And so this is potentially practice changing, because as we'll discuss in the next talk, in terms of new updated guidelines for who to test for H. pylori for the purpose of stomach cancer prevention, there's a lot of race and ethnicity based recommendations, but here you can see that potentially socioeconomic status and healthcare system might be markers as well. So this was another study that is relevant to put into context for why I picked this one. So this one was titled Homologous Recombination Deficiency and Genetic Factors in Gastric Cancer, Insights from the NIH All of Us Research Program. So by way of background, the reason that this study is something to keep an eye on is that recent studies, and especially one in particular from the Japanese Biobank, which was published in the New England Journal, I think about 2 years ago, has identified homologous recombination deficiency genes as important hereditary risk factors for stomach cancer. And there's a very strong interaction with H. pylori. So among individuals with these homologous recombination deficiencies, so BRCA1 or 2, ATM, a couple of other genes as well, that if they're infected with H. pylori, there's actually a 16-fold higher risk of gastric cancer and a lifetime risk, at least in this New England Journal of Medicine article, of about 40%. So this was a landmark study, identifying some of these germline risk factors. And so that's only been shown, and it has been replicated in Asian populations, but has not been shown in a population of European or African ancestry. And so that is the background for this study, which looked at the All of Us cohort. And they did a targeted analysis just because the sample sizes were small, but did look at these 12 homologous recombination deficiency genes, as well as some others that have been associated with gastric cancer. And so what they did was they actually just, it was an interesting study design just because of the limitations in terms of the numbers. And so they pulled out 388 gastric cancer cases from the All of Us cohort and looked at those who did have complete genomic data. And in this cohort, the median age was about 71 years. The range 27 to, there was somebody with age 108. 57% were female and not significantly different than those that did not have stomach cancer. And in these 388 gastric cancers, that 31 unique subjects, so about 10%, did actually have pathogenic variants in these 12 gastric cancer associated genes. And so you can see those listed out here. And so in terms of the actual genes themselves, that the homologous recombination deficiency genes in the BRCA gene family accounted for about 50% of those, with ATM contributing about 41%. So this is just interesting to kind of keep an eye on, especially in the last session where we talked about that gene environment interaction and seeing if we can more precisely predict risk of stomach cancer. There were a lot of limitations with this study because they did not report on the anatomic location of gastric cancer, the histology of gastric cancer, and of course, one of the the thing that's most interesting really is that interaction with H. pylori. So trying to identify who are those individuals who are at risk for stomach cancer when they do have H. pylori infection. And so now shifting over to the esophagus. And so this was the BOSS trial, which is now actually published in Gastroenterology, I think last month or in April. And so this was Barrett's esophagus surveillance versus endoscopy at need, a randomized controlled trial. By way of background, so as we know, surveillance endoscopy for patients with Barrett's aims to detect early malignant progression, but surveillance outcomes have not been evaluated in a randomized clinical trial. And so the aim of this study was to compare overall and all-site cancer-specific survival among patients with Barrett's who are randomized to endoscopic surveillance at set intervals versus at need endoscopy based on symptoms. And they enrolled individuals from 109 UK centers, that individuals who had Barrett's esophagus, which was defined as circumferential salmon-colored mucosa greater than or equal to 1 centimeter or a greater than 2 centimeter tongue, with or without confirmed specialized intestinal metaplasia. And so that's something to keep in mind. And they were randomized to every 2-year endoscopy versus at-need endoscopy that was only offered when there were symptoms. And individuals that were evaluated were followed for a minimum of 10 years, which is important because it's a cancer outcome that takes time to develop. Primary outcome in this study was overall survival in the ITT population, and they also had several secondary outcomes. So cancer-specific survival, time to esophageal adenocarcinoma diagnosis, the stage at diagnosis, frequency of endoscopy, as well as serious adverse effects related to interventions. And so these were the results. So a large study population. So 3,453 patients were included, median age 63, and median follow-up time was nearly 13 years in this cohort. And what they found was that there was no difference in overall survival. There was no difference in all-site cancer-specific survival, and there was no difference in time to esophageal cancer diagnosis or the stage of diagnosis. What was different, though, is that the median number of endoscopy was higher in that surveillance group, which we would expect, those every 3-year interval studies, surveillance exams, compared to the at-need group only had 1 endoscopy. And so the conclusion here is that, endoscopic surveillance did not improve overall survival or cancer-specific survival. And so potentially an at-need endoscopy approach may be a safe alternative for low-risk patients. And these next 2 abstracts that I'll present these are busy, but both of them were poster presentations by the same group, also looking at potentially optimizing the surveillance interval for Barrett's esophagus. And so this group from this study, which was from that Erasmus modeling study, what they looked at was comparing a risk-based approach, so using EsoCheck and EsoGuard, which is a less invasive option that uses a swallowable balloon to collect esophageal cells compared to endoscopic surveillance as a cost-effective screening approach. And they compared different strategies, so either no screening, a once-only screening for individuals with GERD, 10, 15, and 20 yearly screening intervals for screening for individuals with GERD, and once-only screening for the entire population. And ultimately, what they found was that the EsoCheck or EsoGuard may improve health outcomes compared to endoscopy, particularly among lower risk populations such as females and Black individuals, but it was not cost effective at the standard United States threshold, which is above 100,000 per quality adjusted life year. And I will note that this group did use that same MISCAN model that was calibrated to US specific data. So this was using United States numbers. And what they concluded was that the optimal strategy was actually an every 10-year endoscopy for white males with GERD at ages 50 and 60. And no screening was recommended for females and Black males. So again, kind of in line with that de-escalation of screening and potentially surveillance. And this was, again, that same group. And what they looked at, kind of the punchline here was, could they do a risk-based approach to Barrett's esophagus surveillance using TissueCypher and P53 compared to the standard endoscopic surveillance intervals, which in the Netherlands, it's pretty similar to how we practice here in the United States. Interestingly, their starting cohort was at the age of 60, which there has been other modeling data, and I think a clinical study from Rebecca Fitzgerald's group, that age 60 might actually be a better age than age 50. And so they started their model at age 60. And ultimately what they found was that risk-based Barrett surveillance using TissueCypher is not cost effective, but surveillance based on P53 does reduce cost and burden by about 50% compared to endoscopic guidelines and does retain more than 70% of the effectiveness. And so potentially P53-based surveillance as the most cost-effective approach here. And I'll conclude with this last study, which was presented by a UK group. And in this one was focused on hereditary diffuse gastric cancer and looking at the possibility, which with this condition, prophylactic total gastrectomy is recommended because of the very high lifetime risk of gastric cancer. But as we know, total gastrectomy is a morbid procedure. And so the aim of this study was to identify whether or not there are endoscopic predictors of a burden of early signet ring cell carcinoma and potentially delaying prophylactic total gastrectomy for individuals. And in terms of their methods, what they did was they compared, they looked at individuals who did undergo prophylactic total gastrectomy, looked at the burden of SRCCs on that compared to those individuals' total endoscopy histologies and also looking at the last 2 endoscopies that those individuals had. And they created a predictive model. And ultimately, and they used a threshold of, so these individuals, they nearly universally have foci of these signet ring cells. And so what they did was they classified it based on the burden. That low burden was less than 20 of these foci, and high burden was greater than or equal to 20. And so what they concluded was that a low number of SRC foci on the last 2 endoscopies in the absence of advanced lesions did predict a low risk of neoplastic involvement out to about 18 months. And so potentially this is it's safe to enroll low-risk individuals in endoscopic surveillance instead of pursuing immediate prophylactic total gastrectomy. And so that is it.
Okay, thank you, Dr. Shah. Okay, our second talk, it's been a while with this upper GI session since we've actually included the small bowel. Sometimes it gets left out in between, but 28, 30 feet long, very important organ. And we've got an expert today in deep enteroscopy from UCLA, director of the small bowel center there. And Otis Stevens is with us. Come on up, Otis.
Good morning, everybody. I'd like to thank the organizers for giving me the opportunity to give this talk today. And so, as I said, I've been tasked with discussing abstracts from DDW related to small bowel endoscopy. I did mix in a couple of small bowel mucosal diseases too, just because I think they're relevant to what everyone manages as well. Now, each of these studies, they came up with relatively pertinent questions or interesting questions, which is why I included them in the study. I have no relevant financial relationships. Now, the first study looked at a comparison of emergency capsule endoscopy and balloon-assisted enteroscopy in overt, obscure GI bleeding patients. It was a randomized controlled trial. Now, the question they asked was, is this the best way of doing things? And so a little background. The guidelines for management of small bowel bleeding recommend video capsule endoscopy as a first-line procedure for small bowel bleeding. However, capsule endoscopy is diagnostic only, and then you have to proceed if there is definitive therapy to deep enteroscopy. So the question they had was, could you just proceed to deep enteroscopy and could you get the same yield or diagnosis in terms of evaluating bleeding? So they did this by a prospective randomized single center trial in which they looked at 74 consecutive patients who presented with acute overt GI bleeding manifested by melena or hematochezia, who had negative EGDs, colonoscopies, and a negative abdominal CT scan. And they randomized half of these patients, or 37 of them, to capsule endoscopy and the other half to balloon-assisted enteroscopy, and performed these procedures within 48 hours of the last bleeding symptom. And then they classified the yield based on whether bleeding lesions were found, if they had suspected lesions found, or if they had blood stains or no findings. And what did they find? Balloon-assisted enteroscopy had a superior diagnostic yield compared to capsule endoscopy. Bleeding lesions were identified in 67.6% with balloon enteroscopy, and suspected lesions were identified in 16.2%. In contrast, capsule endoscopy only identified bleeding lesions in 37.8%, so a big difference, and suspected lesions in 21.6% of the patients. During the hospitalization, 59.5% of the patients in the capsule endoscopy group had to undergo balloon-assisted enteroscopy for treatment, either biopsy or hemostasis, while none of the balloon-assisted enteroscopy patients required capsule endoscopy. And of course, more patients in the balloon-assisted enteroscopy received hemostasis compared to capsule endoscopy. But there, although there was a slight difference in rebleeding, it wasn't considered statistically significant. So in conclusion, for the study, the overt small bowel bleeding, balloon-assisted enteroscopy in the emergency situation can better identify bleeding lesions than capsule endoscopy, and as a side note, can also treat it and result in faster overall resolution of symptoms. My take, of course, is that while you can proceed directly to device-assisted enteroscopy, and it will give a higher yield, there is a reason why we often start with a capsule endoscopy, and that's determined by our ability to actually reach the bleeding lesion. Now, you know, some people are very proficient at total enteroscopy. I am too. But the issue is if it's a distal lesion that you're talking about, an actively distal lesion in the ileum, you don't want to spend 2.5 hours trying to go one way to get it when you can spend half an hour or 45 minutes going retrograde. So I think there still will be a role for video capsule endoscopy in these cases, but I did think this is an interesting study, and it does give justification for proceeding with balloon-assisted enteroscopy first. Now, the next study looked at accessing the excluded stomach for luminal evaluation with double balloon enteroscopy. It was a result from a retrospective multi-center analysis. And this was a study coming from 3 centers, LSU, Duke, and Cedars-Sinai. And full disclosure, I was a part of this study group. So I am a little biased. But the question they asked was, should we do this? And if we do it, what are we going to find? And that was in relation to Roux-en-Y gastric bypass patients being asked to scope the excluded stomach in these patients. And the question was, how easy is it to do, and what will we find if we do it? And so it was a retrospective analysis of all patients who underwent Roux-en-Y gastric bypass in the past, who had to then undergo double balloon enteroscopy to evaluate the excluded stomach in patients with different ailments. And we looked at this over a 5-year period. The things we measured included a number of factors, including the technical success rate, what kind of findings, and then a number of different factors looking to see if they would affect the success rate. Now, in total, we found 89 patients in this cohort. The excluded stomach was successfully accessed in 73% of the cases. Between you and me, 1 center had a significantly higher rate than that. The reasons for failure included anastomotic angulations and pathology in the afferent limb that was proximal to the excluded stomach. The most common finding on this exam in the excluded stomach was normal mucosa. However, you had gastritis or erythema and erosions in 16%, ulcers in 13.5%, and a various array of other disorders we found, but at low percentage. But of interest, we found 5 gastric cancers, or 5.6%. And that's of interest because the prevalence is typically about 1.5%. So it's significantly higher than what we would have expected. Now, there weren't any additional factors beyond the angulation, anything that affected the ability to exclude the excluded stomach, and the rate of complications was extremely low, only 1 patient with bleeding. So the conclusions, the excluded stomach can be successfully accessed with double balloon enteroscopy in about 3/4 of the patients. Higher if you come to me, but and inflammatory changes and ulcers are the most common pathology. Gastric cancer, however, is a risk in these patients, and it does have a very low risk of serious complications. My additional take to this is that you can access the excluded stomach with double balloon enteroscopy. It's simple, effective, and safe, and should be pursued if it's clinically indicated. But one of the other things that we need to look at is this rate of gastric cancer? Is it a true risk, or is this just something deviation we found in the study? And if so, why? So I think there will be, and we will start to pursue further investigation from that perspective. Now, the next study, this is a mouthful, so bear with me, was relieving the discrimination dilemma of adult autoimmune enteropathy and common variable immunodeficiency disease, 2 rare causes of chronic diarrhea and small intestinal villus atrophy. And that's out of a group from China. And the question they asked was, how can we better diagnose 2 very debilitating small bowel mucosal diseases so that we can treat them earlier and be more effective in the treatment? So both autoimmune enteropathy and the common variable deficiency, CVID, can both present with chronic diarrhea and villus atrophy. And just on a face-to-face clinical presentation, it can be very difficult to differentiate. So the goal of this study was to examine similarities and differences in the clinical manifestations, the lab tests, the path results, and evaluate the long-term prognosis between these two diseases. And they did this via a retrospective review of 26 patients with autoimmune enteropathy and 29 patients with CVID who presented to their center over a 12-year period. What did they find? Well, the autoimmune enteropathy patients had a shorter duration of severe diarrhea, had more significant weight loss, had more severe hypoalbuminemia, and had more severe electrolyte balances compared to CVID. CVID patients, they typically had a history of recurrent infections, which you'd expect with somebody with significant immunodeficiency, and also had lower serum levels of IgG, IgM, and IgA, which is, of course, characteristic of the disease. But they also had a marked decrease in B cells, CD4 T cell counts, and a significant inversion of the CD4-CD8 ratio within the peripheral blood lymphocyte subsets. Endoscopically, there was a significant difference. Autoimmune enteropathy typically presented with active inflammatory changes like erosions and hyperemia, where CVID had no erosions and only a few cases had hyperemia. And then from a pathology standpoint, autoimmune enteropathy patients were found to have reduced goblet and Paneth cells, more pronounced neutrophilic infiltration, as well as more frequent apoptotic bodies. CVID patients in pathology typically had reduced plasma cells as well as deep crypt lymphocytosis. And so in terms of long-term follow-up, and here are just some of the other point, but just looking at some of their additional results, if you look at the weight loss, it's much more pronounced in autoimmune enteropathy, double, quite frankly. And then the other discriminating factors there, we already discussed, looking at the pathology or the endoscopic presentation, a higher level of hyperemia or erythema, and then erosions. Now, in terms of long-term follow-up, both autoimmune enteritis and CVID patients were prone to diarrhea relapse, but patients with CVID had a slightly longer median relapse-free survival compared to autoimmune enteropathy. And overall in the study, while both autoimmune enteropathy and CVID are similar in presentation, they had significant differences in terms of the medical history, the lab tests, endoscopic and histopathologic analysis that could help you differentiate between the two diseases. My additional take was that this was a very important study for two pre-debilitating small bowel enteropathies that we often have a difficult time distinguishing. And it provided, and the issue is that oftentimes knowledge of these has been based on case studies only. So this is very helpful criteria to help us better diagnose these diseases. So the next study is probably one of my favorite studies at DDW because it answered a very practical question that we often think we know the answer to, but don't have any science behind. This was out of the group in Columbia University, and the study was assessing gluten transfer via kissing, a prospective study of celiac discordant couples. Now, the aim of the study, it was based on celiac patients who often have anxiety about gluten transfer via kissing. And the goal of the study was to assess whether there was a significant transfer of gluten via mouth kissing from a partner who had ingested gluten. So how they did this was via a cross-sectional study of 10 couples, one couple who had celiac disease, another one who didn't. And they basically tested potential variations of gluten content in the saliva. How did they do this? Well, they gave the non-celiac partner 10 crackers, which was considered a high gluten load of over 59,000 parts per minute, or about 590 milligrams of gluten. And they administered it with 6 protocols, and they tested the saliva for gluten content in that person in 4 of them at different times, 5 minutes, 15 minutes, 30 minutes, and once immediately after drinking water. And then in 2 of the protocols, they tested to see whether there was this gluten could be transferred to their partners. And so they, after waiting 5 minutes after ingesting gluten, or after drinking 4 ounces of water immediately after gluten ingestion, they had the couple kiss with an open mouth for at least 1 minute, involving tongue and saliva. That's a lot of time for the kiss. So in the 2 kissing protocols, the saliva was collected from the partner immediately after the kiss. And then the saliva samples were also sent for gluten content which was tested via ELISA. Additionally, the partner with Crohn's disease, celiac disease, who after they kissed, they tested the urine for gluten absorption, both the evening after the kiss and the morning after. So what did they find? Gluten was detectable in the saliva of the non-celiac disease partners in all protocols. So whatever they did, they were able, however they administered the crackers, 5 minutes, 30 minutes after water, gluten was detected. They had it in their saliva. However, in the celiac patient who kissed that partner, the level of gluten varied from undetectable levels, less than 5 parts per molecule, to 153.9 ppm. And only 10% of those gluten exposures were above 20 parts per million gluten in the saliva. And in terms of their urine tests, all of the urine tests of the celiac patient were negative except one, in the patient who had the extremely high saliva concentration of 153.9 ppm. So in addition to that, they then questioned the patient with celiac disease to see if they had any symptoms 6 hours or 12 hours after the kiss, and none of them had any symptoms. So the conclusion of the study: although gluten is detectable in saliva after ingestion, significant transfer of gluten through mouth kissing is rare and can be minimized further by drinking prior to the kiss. So you can alleviate the fears of all your celiac patients. So the next study was something I find very interesting, something I've always said, but people always disagree with me. But and they looked at single balloon enteroscopy versus double balloon enteroscopy for the evaluation and treatment of small bowel disorders. This is a systematic review and meta-analysis of randomized controlled trials. And the aim was to directly compare single balloon enteroscopy and double balloon enteroscopy in the diagnosis and management of small bowel disorders. And so how they did this was a systematic review and meta-analysis of all the studies comparing single balloon enteroscopy and double balloon enteroscopy up to November of 2024. Of the studies, there were 4 randomized controlled trials. It involved 387 patients. They found that complete enteroscopy was significantly lower in single balloon compared to double balloon. I told you so. Single balloon enteroscopy and double balloon enteroscopy were considered comparable, however, in terms of diagnostic yield, therapeutic yield, and adverse events. This is just the data showing the yields and everything. But the conclusions, single balloon enteroscopy is inferior to double balloon enteroscopy in terms of complete enteroscopy, or the ability to reach lesions and see the entire small bowel. They were comparable in terms of diagnostic yield, therapeutic yield, and adverse events, but I think there are a number of factors that can contribute to that, which we can go over in the discussion. But my take, of course, is for those of us who've used both devices, this merely confirms what we already knew, that double balloon enteroscopy is a superior device for reaching lesions. Now, the final study I'll go over has to do with fecal calprotectin in the small bowel Crohn's disease and whether it's a reliable tool. And this comes out of a group from Portugal. So the basis of this study was to investigate the relationship between fecal calprotectin levels and small bowel inflammation activity in patients who are diagnosed with small bowel Crohn's disease. And so they did a retrospective study looking at patients who had small bowel Crohn's disease who also underwent capsule endoscopy and fecal calprotectin testing. And they categorized these patients into 4 groups. So one was a group with no inflammation at all. One was a group with proximal small bowel inflammation, another with distal small bowel inflammation, and a third with inflammation throughout the entire small intestine. They excluded all patients with colon inflammation to minimize the risk of co-founders. And the results are there, and what they showed was that there are statistically significant differences in fecal calprotectin levels between patients who have inflammation throughout their entire colon compared to patients who have proximal inflammation and distal inflammation, with no significant differences in their Lewis score or their capsule score for inflammation. Fecal calprotectin patients had a positive correlation with fecal calprotectin had a positive correlation with the Lewis score in the second and third tertiles of the small bowel, in other words, in the mid and distal small bowel, but it had no correlation in the first tertile or proximal small bowel. Fecal calprotectin demonstrated good predictive capacity for identifying inflammation in the distal small bowel and total small bowel inflammation, but not with patients who had no inflammation or proximal inflammation. So the conclusions, fecal calprotectin levels correlate positively with the presence of small bowel lesions in the mid and distal small bowel, but not in the proximal small bowel. And this kind of highlights the importance of additional endoscopic therapy or endoscopic imaging in these patients with Crohn's. Now, they've mentioned the importance of capsule endoscopy in these patients with Crohn's. My additional take on this is that capsule endoscopy is actually not as sensitive in the proximal small bowel. It does miss lesions there. So it may also highlight the need for additional investigation, such as enteroscopy as well. And that's it. Thank you.
Okay, for our state-of-the-art talk, I'm going to invite Dr. Shah back to the stage, and she's going to tell us about current approaches to primary and secondary prevention of gastric premalignant conditions and gastric adenocarcinoma in the U.S.
All right, thank you again. So I'm really excited to give this talk because, as many of you know, it's really been gastric cancer in the U.S. has really been an overlooked cancer, and we'll go through potential reasons why. But it's really been an exciting time with a lot of work and research for gastric cancer prevention that in at least the last 2 to 3 years has really resulted in some exciting breakthroughs in the form of policy and guidelines, which we'll go through today. But there's hopefully, we can really expand in the question and answer that there's still a long road ahead, especially in endoscopic detection of gastric cancer and as an early stage gastric cancers and risk stratification. So we'll focus on the current approach to primary and secondary prevention for gastric cancer in the U.S. These are, again, my disclosures, nothing relevant for this talk. And so gastric cancer remains a global health priority. It is still in 2025 the fifth most common cancer and the fifth leading cause of cancer mortality worldwide. And on our current trajectory, gastric cancer cases and fatalities is projected to increase by 62% by 2040, again, if we stay on our current trajectory. And as you can see in this heat map, the incidence of gastric cancer varies according to country, and there's wide global variation. But what's not readily appreciated in this heat map is that immigrants from high incidence countries, when they immigrate to lower overall incidence countries, they actually retain that risk. And so for countries with high diversity like the United States, there's actually a mixed incidence of gastric cancer, really driven as well by those immigrants from high incidence countries. And so to illustrate that point further, this is a population-based analysis that we looked at California Cancer Registry data, evaluating the gastric cancer incidence among the 10 most populous racial and ethnic groups in the United States. And compared to the reference group of non-Hispanic whites, you can clearly see that there is a substantially higher risk of gastric cancer, non-cardiac gastric cancer, in all non-white groups, anywhere from 2 to over 13-fold higher risk. And in some groups, especially Korean Americans, the risk of gastric cancer approaches and even exceeds colorectal cancer incidence. And that's an important point because, as we know, colon cancer is something that we routinely screen for. And so gastric cancer, when it's diagnosed in the US, is more often in the advanced stage. And so those early stage cancers going potentially undetected. But gastric cancer is preventable. And I say preventable because about 90% of gastric cancer is related to modifiable risk factors, the primary one being H. pylori, and also because secondary prevention through early detection of early stage cancers really does save lives. And so we'll focus on first primary prevention, where the pillar there is really H. pylori eradication. And so in 2025, H. pylori is still the most common chronic bacterial infection worldwide and the #1 infectious carcinogen. And that's why I liked that abstract that I presented earlier, that we think of the United States as low H. pylori prevalence, but there really are high-risk populations, in lower socioeconomic status, racial and ethnic minority groups, immigrant populations, 60% with H. pylori exposure. And fortunately, the majority of people that are infected with H. pylori will never develop gastric cancer, but that 1 to 3% that will, again, translates to gastric cancer being the 5th most common cancer-leading death worldwide. And so what we're left with is that we can't predict who will versus will not develop gastric cancer. And so ultimately, we have to treat everyone who is diagnosed with H. pylori infection. And that recommendation is across international guidelines, across US guidelines, and is based on consistent randomized controlled trial data, as well as observational studies from the United States, consistently showing that there's about a 40% reduced risk of gastric cancer associated with H. pylori eradication, and about a 20% reduced risk of gastric cancer mortality. And this is the most recent updated meta-analysis from Alex Ford and his group, where they did actually add in the US, we have observational studies. And again, those ones are consistent with the over 11 or 8 randomized controlled trials globally. And so one of the newer developments is that now in the United States, we do have clearer guidelines about who to actually test for H. pylori for the purpose of gastric cancer risk reduction. And so, as you know, the majority of people with H. pylori are going to be asymptomatic. And so if we need to treat everybody who's diagnosed, the question really becomes, well, who do we test? And previously it was unclear, it's clear when individuals have symptoms, but when we're thinking about that asymptomatic population, who do we test? And so this was just published a few months ago in the ACG, the 2024 ACG guidelines for H. pylori testing and treatment. And so what I've highlighted here are those two main categories of who to test for the purpose of gastric cancer prevention. And the first group includes those with current or prior history of gastric premalignant conditions or gastric cancer, people with a first-degree relative with gastric cancer, people with autoimmune gastritis, and a much larger category, other individuals at increased risk for gastric cancer, which includes non-white races, ethnicities, immigrants from endemic countries, or hereditary cancer syndromes. And I would argue, based on that abstract that I presented, also individuals with lower socioeconomic status, or in safety net urban settings. Another category is the one highlighted below. So adult household members who test positive for H. pylori. And this recommendation is based on robust data from Asian countries, including randomized control trials, which consistently show that this approach, this family-based approach of test and treat, is associated with higher eradication rates, as well as lower risk of reinfection with H. pylori among families, and with reduced gastric cancer incidence overall. We won't go into treatment in this talk just due to time, but I do want to emphasize really the importance of always performing a post-treatment test of cure in individuals that we do treat for H. pylori, because that risk reduction in terms of gastric cancer is related to actually eradicating H. pylori, that individuals who have persistent H. pylori stay at risk. And so another key point is that it relates also again to that abstract that I presented, which the biggest bang for your buck with H. pylori eradication is going to be before the development of gastric premalignant changes. And individuals who already have gastric premalignant changes, which includes atrophic gastritis, gastric intestinal metaplasia, or gastric dysplasia, they remain at risk for gastric cancer despite H. pylori eradication. And so that's why primary prevention really should be thought of as an adjunct. And that underscores the role of secondary prevention through endoscopic screening for the purpose of early detection of gastric cancer. And so we'll shift over to secondary prevention. So in other countries, specifically South Korea and Japan, they have been doing on a national level programmatic gastric cancer screening for decades. And interestingly enough, this has, in the United States, we harp on these randomized control trials, like we need the trials to show us that something is effective. In these countries, they actually implemented gastric cancer screening based on epidemiologic evidence showing that there's high incidence, high mortality, and the fact that if we resect an early stage gastric cancer, it's curative. We have that data in the US, but we are behind the 8 ball. And so this was because of that longitudinal experience with screening, that there are several observational studies from South Korea as well as Japan. And so this was a study that was published in Gastroenterology a few years ago, looking at comparing gastric cancer outcomes in individuals who underwent screening versus no screening. And in this meta-analysis, about 340,000 individuals were included. And what they found was that endoscopic screening was associated with a 40% reduced risk of gastric cancer-related mortality, but there was no reduction in gastric cancer incidence. And that highlights that main point that the driver of the mortality benefit associated with screening is that ability to detect an early stage gastric cancer and offer that potential for cure. And in the US, in terms of data for screening, the data are actually indirect, and indirect in the form of epidemiologic evidence that I presented, identifying those high-risk groups. It's in the form of evidence from outside of the United States, so the endoscopic screening experience outside of the US, and also in the form of modeling studies. And so this is one study that we completed a couple of years ago, looking at strategies for endoscopic gastric cancer screening based on race and ethnicity, using race and ethnicity as a surrogate marker of gastric cancer risk based on the epidemiologic evidence that I presented earlier. And so what we modeled was a 50-year-old individual. It was 50, the age for screening was 50 at the time that we did this study, but the same model worked at age 45. So 50-year-old person undergoing colonoscopy for colorectal cancer screening based on race and ethnicity. And could fall into one of three strategies. So upper endoscopy with mapping biopsies if intestinal metaplasia was identified, EGD with mapping biopsies and ongoing endoscopic surveillance, irrespective of what, if it was normal mucosa, which is the approach currently practiced in some Asian countries, and then no endoscopic screening. And ultimately what we found was, oops, I'm not sure how to go back, but ultimately what we found was that endoscopy for gastric cancer screening at the time of colonoscopy for colorectal cancer screening was cost-effective for all non-white groups at that threshold of less than $100,000 per quality-adjusted life year. And the main driver of that cost benefit and life benefit really was the benefit and cost reduction, the cost saving associated with diagnosing an early stage cancer and offering that potential for cure. The model was also sensitive to two things: the prevalence of intestinal metaplasia, as well as the rate of progression of intestinal metaplasia and dysplasia. So the rate of progression of those premalignant changes. And so in terms of the prevalence of intestinal metaplasia, we don't actually know what the prevalence of intestinal metaplasia is in the United States because it's an endoscopic diagnosis. And so, of course, we're not doing endoscopies in everybody on a population basis. But based on the studies that we do have, especially some large endoscopy cohorts, that the prevalence of intestinal metaplasia, it's actually common in the US, especially among high-risk groups, so about 15 to 25% of individuals in the US. And if we look at, there was a study, was a pathology database of individuals who had undergone endoscopy with at least one biopsy. So, and it was over 1 million patients in the US. Prevalence of intestinal metaplasia without any risk stratification was about 5%. So common, and even more common in individuals with potential risk factors. We care about intestinal metaplasia, of course, because it is associated with an increased risk of gastric cancer. And overall, if we look at all individuals with intestinal metaplasia, that risk of gastric cancer is actually, it's low overall. So about 1.6% at 10 years based on meta-analyses. And to put this into context, this risk of progression is actually on par with other precancerous conditions of the GI tract. So non-dysplastic Barrett's as well as low-risk adenomas have a similar rate of progression. But this is just baseline risk. And that risk of progression varies depending on the presence of additional risk factors. And so like I mentioned in that model in the simulation study, that rate of progression is important. So the prevalence of intestinal metaplasia and then the rate of progression. And so we don't have time to go through all the risk factors for progression, but this is, I just wanted to list them out because the presence of these risk factors is associated with 2 to 5-fold, potentially even higher risk of progression to gastric cancer. And so it includes advanced stages. We call it the Olga or Olgim stage, which is used internationally, but more advanced stages that incorporate severity as well as the extent of intestinal metaplasia, incomplete histologic subtype, corpus extension, persistent H. pylori, family history of gastric cancer. And I also included those host genetics based on, again, the landmark study from the Japanese biobank and potentially US data that I alluded to in the abstracts. And so risk stratification truly is key. One thing that you won't see on this list, though, is race and ethnicity. And so even though race and ethnicity are associated with a higher prevalence of intestinal metaplasia, it's not actually an independent risk factor for progression. And these are the factors that we know of are associated with higher risk of progression. And so there are a lot of international guidelines regarding intestinal metaplasia management, and they're pictured here. But what I want to emphasize is that actually there's a lot of confusion around the guidelines, but there's actually alignment in terms of the importance of risk stratification in all individuals who are diagnosed with intestinal metaplasia, and that individuals who are truly low risk don't warrant endoscopic surveillance. And so again, risk stratification. And in the United States, there's been a lot of progress in the past 2 to 3 years in the form of guidelines. And I've listed these out. We won't go through all of them, but just to, again, emphasize that there now are guidelines for gastric cancer primary and secondary prevention in the US. One thing to emphasize here is, again, that alignment, that there is alignment in terms of identifying those high-risk individuals, as well as the approach to primary and secondary prevention. So we talked about primary prevention with the ACG guidelines and identifying those high-risk groups to test and eradicate of H. pylori. And so now we'll shift over to that secondary prevention and some of the updated guidelines. So this is the AGA Clinical Practice Update, or CPU, on screening and surveillance in individuals at increased risk for gastric cancer in the United States. And clinical practice updates, or CPUs, I like to think of them as like sisters to the guidelines, that they are, they're meant to provide clinically relevant guidelines for topics of high clinical importance, but where the level of evidence is not necessarily amenable to grade methodology. And so gastric cancer screening is one of those that we don't have clinical trials. We don't have necessarily that robust comparative evidence, but we know that it's an important topic. And so typically these clinical practice updates are set up to have about 15 or so best practice advice statements along with supporting evidence. And so in this document, the first best practice advice statement is focused on targeted screening, targeted endoscopic screening for high-risk groups. And so those high-risk groups are highlighted in this table off to my right. So individuals to consider for gastric cancer screening starting at the age of 45 include early generation immigrants from moderate to high incidence gastric cancer regions, which are defined here. And that is based on strong data to suggest that immigrants from high incidence countries retain their gastric cancer risk and mortality on immigration. So family history of gastric cancer in a first degree relative, non-white racial and ethnic groups with established moderate to high incidence gastric cancer. And with this one, there is an asterisk. Again, identifying that race and ethnicity really is a surrogate marker of risk, but we do know that there is disparity in terms of gastric cancer incidence mortality, but still really pushing for biologically based risk stratification, but at least for now, having this as a surrogate marker. Personal history of chronic H. pylori infection and at least one of the following risk factors listed there. So regular tobacco smoking, chronic consumption of a high salt diet, red meat, processed meats and foods, and individuals living under persistent poverty in the United States. And that persistent poverty recommendation was based on the AACR cancer disparity report that was published, I think like about 2 or 3 years ago, showing a 42% higher gastric cancer mortality in individuals living under persistent poverty. BPA2 identifies endoscopy as the best screening test. And then BPA4 is really just emphasizing that H. pylori eradication or screen and eradicate alone is insufficient. It should be an adjunct because individuals with premalignant conditions at baseline still progress despite H. pylori eradication. This guideline also includes, or the CPU also includes guidance regarding endoscopic surveillance for atrophy and intestinal metaplasia, as well as the management of gastric dysplasia. And so for atrophy and intestinal metaplasia, again, just emphasizing risk stratification. So individuals with at least one of those risk factors that I listed out previously, endoscopy every 3 years, and potentially a shorter interval if there's multiple risk factors, and that is also based on large observational cohort studies. For dysplasia, the main branch point here is visible versus non-visible lesion. And so all dysplasia should be confirmed by an expert pathologist, and any visible dysplasia should be resected. And then the ongoing endoscopic surveillance intervals really do depend on what that final histology is. So if it's indefinite dysplasia, 1 year, low grade, 6 to 12 months, and then high grade, 3 months. I just put these here just to also highlight that the ACG had published maybe about 2-3 months ago, also similar guidance for gastric premalignant conditions. Again, non-dysplastic and then dysplastic, but with alignment with the AGA. And so I wanted to conclude with what I call just the elephant in the room, especially on this topic. And so as I've stressed to you, the importance that mortality reduction for gastric cancer screening is driven by the ability to detect early stage gastric cancer and to detect gastric cancer. And this is analogous, of course, to just the experience with colonoscopy and ADR. And it's humbling because studies, even in expert hands, that based on large meta-analyses, the rate of missed lesions is about 10% and potentially higher in individuals or in endoscopists with less experience. And this is a picture from my patient. Like, these lesions are extremely subtle. And so this one you can see at about 5:30 that there's a lesion there, and that actually came back as gastric adenocarcinoma. So extremely subtle. And whereas we've had colonoscopy quality metrics for many years, for a long time, we did not have, until recently, any quality metrics for upper endoscopy. And so now, just in the past year, all three societies have come out with quality metrics for upper endoscopy. And there's alignment there as well. And so we don't have time to go through those, but I would encourage you to read those, because that is new guidance and something that we might not be familiar with. But really key here is, especially for the gastric exam, we know that EGDs, people just fly by to catch up on their colonoscopy schedules and all that, but really take your time. I showed you how subtle those lesions are, and you know that the risk of gastric cancer is high, especially in high-risk populations. So key things are to wash and aspirate all fluid and debris from the luminal surface. So just like we have the quality of the bowel prep, like really just focusing on endoscopic, just clearing the space, insufflating properly, using a high definition white light endoscopy system. I routinely use image enhancements, so narrowband imaging on the Fuji systems, BLI, LCI, and then ensuring sufficient inspection time. Just like we see with colonoscopy, that increased withdrawal times associated with increased ADR, same exact experience in the stomach. That increased time has been associated, that there's a 6-minute cutoff is associated with higher rates of detection for those early lesions. And you can see intestinal metaplasia here, and then Sydney protocol biopsies where appropriate. So take-home points. There are identifiable high-risk populations in the U.S. who are likely to benefit from primary and secondary gastric cancer prevention efforts, and this includes early-generation immigrants from high gastric cancer incidence countries and regions, non-white groups, family history of gastric cancer, and individuals with persistent H. pylori infection with other risk factors. Like I said, we do need to move away from race and ethnicity-based risk stratification and ideally having biomarkers, but we're still a bit of ways away from that. And so to just have the opportunity to act now, because race and ethnicity is a surrogate marker of risk. Primary prevention, we now have guidance, ACG guidelines, and the AGA clinical practice update, using an H. pylori screen and eradicate approach in individuals at increased risk for gastric cancer, and confirming eradication in all individuals when they are treated. And like I've emphasized, that greatest impact of H. pylori eradication on gastric prevention is before development of premalignant conditions, and based on modeling studies in the US and also robust evidence from Asia, that targeting that age 20 to 40-year-old. And so really continuing the conversation with our primary care providers and colleagues as well to make sure we don't miss that opportunity. And then secondary prevention, which includes screening and surveillance endoscopy for early gastric cancer detection. So we have guidelines here that I've listed out, but really emphasizing that elephant in the room, that we do need to hand in hand improve our upper endoscopy quality to make sure that we don't miss these lesions. Thank you very much.
Thank you both. What a great couple of presentations. I'm sure there's going to be a lot of questions here. So Dr. Lund.
Conditions. I remember the old literature, even with H. pylori, people with H. pylori with duodenal peptic ulcer disease had a decreased incidence of gastric cancer. So when I looked through all this, almost every premalignant condition, there's one common factor, and that is low acid. And if the mid-body gradient curve has a robust, thick oxidative mucosa, and this patient is making acid, the intestinal metaplasia, the antrum isn't so important, isn't so interesting to me. But if they have true pan atrophy, that's a whole different ballgame. So can you comment on acid, number one? Number two, what do you do with PPIs and your people at high risk? Do you care about acid? Just
I see. So thank you for those questions. And to summarize, we know that older literature and really nice physiologic studies, just in terms of also the anatomic distribution of H. pylori in the stomach, that antral infection causes that increase in acid production. We see duodenal ulcers there. And then versus corpus infection and extension of H. pylori leading to corpus atrophy and higher risk of gastric cancer. And so it is, especially in our era of PPIs, it's kind of hard to still suss that out. And so we still treat all H. pylori the same because we know that still gastric and duodenal ulcers are still a complication of H. pylori. And so even if somebody does just have, a duodenal ulcer presentation, like we still treat it the same way. And so you still get that same gastric cancer risk reduction. Where I do think the field would be, I really hope that we start to move, though, towards better understanding which individuals with H. pylori infection are at risk of complications. So if we have like a 60% prevalence of H. pylori in some of these higher risk groups, to treat everybody, when we think of those downstream implications, when we know that only a small fraction are going to be at risk for complications. And that's why I highlighted that abstract looking at these genetic markers of risk that we are actually getting closer and closer, especially in Asian populations, to identify those. So take home point there is still, yes, there are differences in H. pylori and in terms of the actual clinical manifestations, but we still need to treat it the same way. We need to eradicate everybody. And then in terms of the PPI and kind of by the same vein, PCABs and in individuals who already have like corpus atrophy or intestinal metaplasia, where what I counsel patients, because we know that a lot of people are on these medications. And so in my patients, especially with autoimmune gastritis and also severe atrophy or moderate to severe atrophy and intestinal metaplasia, I am getting them off of those medications. Because if you do look at the overall, we don't see an increased risk of progression in individuals with intestinal metaplasia who are on these potent acid suppressing agents. But if you look at the groups that actually have severe involvement, that there is actually a higher risk likely related to that achlorhydric, hypochlorhydric environment.
So in gastrointestinal bypass patients, it's not uncommon for them to become anemic, I think partly because of malabsorption. And I don't think most of us in private practice have the ability to find someone like yourself to always go into excluded stomachs. So how do we decide which ones of these people we would do that to? Because it's not going to be an easy thing to get someone to want to go look in an excluded stomach if their only indication is, say, iron deficiency, but I don't know what other ways one would analyze that. So is there any way of deciding that?
Yeah, thanks for the question. So typically when we look at the excluded stomach, it's because we're trying to find something that we couldn't detect anywhere else in the visible small bowel. So in the case of patients with iron deficiency anemia, you've done a colonoscopy, you've done an upper endoscopy. The question is whether the capsule has anything or not. So yes, you're right. It can be the absorption because most iron is absorbed in the duodenum. And with patients who have gastric bypass, they obviously don't have the intact duodenum to absorb. But if they have prolonged iron deficiency anemia and you do not see any lesions on capsule to explain everything, then I think it is worth it. Because as I said, one of the cases in which we found gastric cancer was for that very reason. It was because somebody had iron deficiency anemia, which for years everyone had assumed it was just because of the gastric bypass. And they went up there, we found gastric cancer. So I think it is a reasonable indication to do so.
Dr. Cleek? Oh, was there another comment? No? Okay.
Thank you for the talks. Just a couple of comments first. I had, Dr. Shah, you're right. I had a couple of patients that there was very subtle findings in the stomach. And, usually think it's a little gastritis. I was just taking biopsy to check for H. pylori and turned out to be gastric cancer. And so that was very early and they were safe and no problem after that. The other thing is there was a patient I had that actually had nothing significant, but this patient had biliary obstruction, and we thought, well, maybe we should look for cholangiocarcinoma or whatever, but she also had cirrhosis. So when I went in there, I was looking for varices, but there was a little irritation in the stomach, and I took some samples, but I was again checking for H. pylori because I just wanted to eradicate all the risks. It wasn't really to look for cancer. And it came back as adenocarcinoma, but then when we went the second time around, the third time, fourth time, there's nothing there. We couldn't find it at all. I don't know if you have any comments regarding that. She had endoscopic ultrasound, PET scan. She was sent to a tertiary center everywhere, and they couldn't find anything. It's been more than a year now, and she's negative. So that's one thing that I was going to ask you. And then go ahead and maybe you can answer that first, and then I'll proceed to the next question. Sorry.
Yeah, no, that's very interesting. So the question, if I understood it, well, the first point was really just how subtle these lesions can be, and it gets a little bit, more difficult than two. Also, if there's like extensive, atrophy and other changes in the mucosa that you need to pair with then too. And in the setting of active H. pylori causing gastritis, that some of the features can also be a bit muddled. And so my stance is it's a hard problem because in the US we're not, I wasn't trained in fellowship to look for these lesions. And so it really is just an active practice to kind of understand what those features are, understand intestinal metaplasia, what it looks like endoscopically, and go from there. Regarding your comment about the patient who had adenocarcinoma on essentially a random non-targeted biopsy, that is curious and had she had cross-sectional imaging and also,
Everything was done and negative.
Yeah, and confirmed by a second pathologist that it was
Third
adenocarcinoma.
pathologist.
Yeah, I mean, I think you did all the right things with endoscopic ultrasound and taking,
And we even
continuous
checked
blood.
the other patients that they were in the center, make sure that we didn't make any mistakes with their pathology slides and so on. There wasn't anything like that.
But I think this really points out huge differences between US clinical practice and Japan and Korea. And part of it is just incidence, right? So Japan, 140,000 cases of gastric adenocarcinoma a year, US 30,000, right? For a much bigger population. For a Japanese man, it's 40 per 100,000. For an American male, it's maybe 4, at most. And we have not been looking for this. Endoscopists aren't trained to do it. They don't routinely take their time and use mucolytics, I don't think, on a regular basis. I don't think our scopes are probably the same. I don't think our pathologists are the same. I'd be interested to see if anybody here has a general pathologist in their practice who is routinely recording OLGAM or OLGA and commenting on the severity of, intestinal metaplasia or atrophy. I don't think it exists in the US, and yet in, Asian studies, that's the greatest risk factor. That's the thing you want to know. It's not necessarily, can you see IM in the antrum or some IM in the body? These are the risk factors that they've identified. So I think we need to do something because it's a cohort effect, right? So we got to help the people now because hopefully in the future, there won't be any more H. pylori and most of this problem will be gone. So it's important to do it now, but there's so many things. Like, I wonder if you reached out to US pathology societies and said, are we going to start reporting this stuff, guys? Or
Yeah, and even at my own institution, I can't get the pathologist to report even subtyping incomplete versus complete. And I've just stopped.
No,
asking.
that
That's a
is
simple.
true. We had to
simple
actually
thing.
ask our pathologist to look for complete and incomplete, and finally they did it. So now they're doing it routinely for us.
Right.
Because I came to one of these talks, and I think it was Dr. Satish Rao talk, and he said, you have to do that because that's important. Okay, we'll do it. We talked to our pathologists, now they're doing it, which is good. I think we just have to change practice.
Yeah, that's the thing. It's like, and that's why the guidelines were exciting, because now there's at least something that you can stand on. Because we had actually met with the US Pathology Society, and there was just a disconnect because they didn't actually think that gastroenterologists thought it was important. And so for them, they were like, why should we do this if you don't think it's important? And so now that there are guidelines to say that, no, we think this is important.
Time
This
to
is
go
the
back.
international standard. And what we're actually pushing for, because now there's studies looking at the endoscopic scoring of intestinal metaplasia that correlates very well with OLGM staging. And so if we can actually now just take it upon ourselves to more reliably detect and stage intestinal metaplasia and endoscopically, then because OLGM is time consuming for pathologists, and most of them are not trained in the US in that using that system.
So Dr. Shaw, one thing fast. So I have a lot of Hep B patients who are Asians, right? So they're in their 20s, 30s, 40s, 50s. So should I then check H. pylori for all of them? And they're all asymptomatic, obviously.
Absolutely. Yeah. Absolutely. I would check H. pylori.
Whether they're first generation or immigrants, right? So
Absolutely. Because in that also is based on the family-based testing that I discussed, that even for second generation, like within that family, that there is a higher risk of H. pylori. But then also not forgetting that H. pylori screen and eradicate is only an adjunct. And so especially by the age of 40 is where we are seeing those gastric premalignant changes already occurring. And so, the potential discussion of endoscopy as well.
just one fast question for balloon enteroscopy. So there are patients, I think, looking at your abstract, you mentioned that you had an easier time to getting into the stomach, but there are Roux-en-Y gastric bypass that are long limbs and short limbs. So some of the short limbs are probably faster, because I've used pediatric colonoscope and I've been able to get into the stomach with the short limbs, but not with the longer limbs, of course. A few of the short limbs, but not all of them. I wonder how easy it is to use a single balloon enteroscope to do these.
Using a single balloon instead of a double balloon to get to the excluded stomach.
How fast is it and how easy it is?
I think
I'm wondering whether we should incorporate that in our practice or not.
Okay, yeah. So I think you can still get there with single balloon, and I think it is effective. I think the issue that some people have is at the jejunal anastomosis. Sometimes the angle can be sharper and more difficult to get through. And the problem with single balloon is you don't really have the extra balloon to anchor you there and get through the angle. But I think you can get there with single balloon. And I think it is still a relatively effective tool at getting there. And if you do have it, you should incorporate it in your practice.
One other.
How long to get there? It varied for us because we were doing pathology in that, but maybe half an hour, 45 minutes. Assuming you go through the right channel, because one of the things is you could go down the wrong hole and then you'll be going forever. But yeah, if you go down the right channel, about half an hour, 45 minutes.
Yes, sir.
Question, Dr. Shah. I have a patient with gastric maltoma, biopsy negative for H. pylori. I send them to the oncologist. They treat them and don't remember which chemo they give. I repeated the endoscopy like 6 months later. The intensity is way less, but the biopsy is still positive for gastric maltoma, still negative for H. pylori. How do you follow those patients?
Yeah, it's a good question. I actually have two patients similar to that I'm actively following as well. And here it really is just a partnership with the oncologists and deferring to their expertise. And it also depends on the individual patient and their ability then to tolerate like a systemic chemotherapy. And so that would just be on an individual basis. But the recommendation is that even if for the initial treatment, that individuals with malt lymphoma, even if they're H. pylori negative, to still treat them for H. pylori. And there isn't anything to follow up if they've been negative before treatment. And for me, usually it depends again on the patient, but I will sometimes prescribe like a rifabutin-based therapy just because it still is very tough for patients to tolerate, an optimized Bismuth quadruple therapy regimen. And so just to kind of limit the potential for like partially treated H. pylori infection. But I would, in those cases, I defer to the oncologist and work with them.
And how often you do EGD on them?
There's no set guidance regarding. I usually do it at 3 to 6 months, and then if there's improvement, then at least again anecdotally, like another 3-6 months just to see if there is going to be resolution. But in the patients that they have that initial improvement, I've never seen actual resolution then, and so I think just deferring again to the oncologist.
So considering they are high risk, would you do HD every 3 years?
I would still, and probably sooner than that. I would be a bit more conservative and probably at the 1 year mark. And then if it's consistently negative after 2, then, discussing extension, but we don't have the actual data. So it's a no data zone.
Just one quick one for Dr. Stevens. So thalidomide or octreotide for recurrent angioectasia bleeding when you're tired of doing all the double balloons?
For me, it's octreotide, and for a number of reasons. So they recently had an ocean study that looked at the efficacy of octreotide in small bowel angiectasias, and it was relatively high, comparable to thalidomide. The issue I have with thalidomide are the side effects. Peripheral neuropathy within the first 4 months after use is about 56%. But if you extend it longer, 6 months or longer, it can be as high as 80%. Now, there is a caveat to that. With the use of thalidomide, usually after 4 months, we give a drug holiday, and the effects can last up to a year. And so you can try and mitigate some of these symptoms with that. In other words, if you stop after 4 months, the benefit you're seeing will continue, and then you can try and restart it. But, the peripheral neuropathy is pretty pervasive, and it's something I'd like to avoid. So I avoid thalidomide if I can. Now, the other caveat I'll add is that there is an analog to thalidomide, lenalidomide, which you can use, which has much less side effects. And so that's another option too. But my starting drug is always octreotide.
Kelvin.
Kelvin Wynn from Kaiser Orange County. This question for Dr. Shah, and thank you for the talk on the topic that I usually tell my patients that gastric cancer is something that scares me more than any other parts of the GI tract. So the question arises from the fact that, for liver, we know that we treat patients with Hep C, and the fibrosis is actually still ongoing even after the patient gets the SVR 12. So the question is, even if my patient with HP and I treat them, is there any molecular change even after you completely eradicate the patient? This might change my mindset. At least for me, I think, when I treat someone for HP, I think my brain just stops right there. But then if we know that it's a molecular change with these patients chronically, and God knows how long they've been accumulated this risk over the years, that might change my risk stratification when it comes to endoscopy for these patients.
Yeah, it's a great question. So it's and there's 2 ways that I'll answer. One in terms of current, and then kind of what potentially our future practice might be. And so currently, like I mentioned in the talk, that if somebody already has, moderate to severe atrophy or intestinal metaplasia, that those individuals, if you treat H. pylori infection, then those changes, especially moderate, if you're in the moderate severe range, are still going to persist. And so that individual is still at risk for progression to gastric cancer. And so they still should undergo surveillance because the molecular changes, the damage has already been done. We think that things that progress it, even in the absence of H. pylori, are going to be the changes to the microbiome that have occurred, other insults from dietary aspects, smoking, and then, of course, their underlying genetics and those aspects. So those individuals still should be followed after eradicating H. pylori. The question of if somebody has H. pylori infection and their endoscopy shows normal gastric mucosa, they don't have any of those premalignant changes, then what is that individual's risk? And we honestly don't know. That's why I think these studies that are looking at somebody's individual germline risk are very interesting, because there, that interaction of H. pylori and these genetic risks, if you take H. pylori out of the picture, in those individuals is there's still actually that risk of progression. So if somebody has a low genetic profile, even if they have persistent H. pylori, their risk of gastric cancer is extremely, extremely low. And there was a study that was published in JAMA looking at it was a Chinese population, very, very low risk versus those who did have these underlying germline mutations. And so right now, kind of our only surrogate is family history or any other additional risk factors. That's probably an individual that you would want to continue to follow endoscopically. But in my practice, if somebody has been eradicated of H. pylori and they have no other risk factors, then I'm not continuing to follow them.
Thank you.
With respect to zonal cell or malt lymphoma, do you think overall the oncologists tend to overtreat them really? I mean, when you send them on, they're getting chemo, they're getting radiation, and there are many of them that we treated just with antibiotics, eradicate H. pylori, and you go back, and I've followed them for years, and there's nothing there. Is that a general feeling?
Yeah, that I think I don't have as much because we know that malt lymphoma is still a rare cancer, much rarer than adenocarcinoma. So it is possible that we are overtreating them, but I think there are still we don't have an accurate method of clearly discriminating those individuals who will actually have more rapid progression from those who won't. And so I think then we are left to treat everybody on an individual basis. And that's where I kind of mentioned, we use like the frailty index and other metrics of, is this individual going to be able to tolerate the systemic treatment for malt lymphoma? Because it is tough to tolerate. And so we have several patients that we end up watching them, especially on the VA side, that a lot of them we know would not tolerate the chemotherapy.
Okay, last question.
Charles Menz-Ventura for Dr. Otis. Push enteroscopy with 170 centimeter endoscope versus the first tertile to try to look for patients that have bleeding that you didn't see and you've had a previous or recent capsule endoscopy. In other words, you're stuck, you've done your upper, you've done your lower, you get the capsule may be negative, may be positive, but we know that the first, in the third and fourth portions of the duodenum, that you don't see that as well with the capsule. Push enteroscopy or wait for you to take care of it as a double balloon, i.e. use 170 centimeter long scope, your choice.
Push enteroscopy, and I'll tell you why. So you're absolutely right. Capsule endoscopy does miss the proximal small bowel. And at the same time, a lot of the lesions you'll find, especially when you're looking at things like small bowel angiectasias, are often found in the very proximal small bowel. So I think there's significant utility to utilizing push enteroscopy first. And that's actually what I typically do. I have access to double balloon all the time, but I don't always want to spend, a long time in these patients. So if they've undergone EGD, colonoscopy, capsule endoscopy, oftentimes I'll start with a push enteroscopy first before pursuing double balloon enteroscopy because I think it's higher yield.
Okay, our first speaker needs no introduction to this group, one of our former Lifetime Achievement awardees. Too many titles to name, but I'll just say Vice Chief of GI at UCLA. And importantly to me, she's in education as the program director there. Lynn Chang just flew in from Colorado or other parts unknown. We're very happy to have her here to talk about abstracts from GDW.
Hi, everyone. Thank you for staying and enjoying the meeting, and I hope you'll find this interesting. So Allie and I did pick completely different. I just stayed away from the microbiome, so I knew I would be safe when I picked some abstracts. These are my disclosures. Okay, so I just picked, I think, about four, and I try, or 4 or 5, but I tried to pick ones where you could apply this information right now in practice. So this is the first one. It's increased GI symptoms in individuals with celiac disease and coexisting irritable bowel syndrome. A national survey-based study was done by the Cedars-Sinai and Columbia group. So this is the background. Many individuals with celiac disease continue to experience GI symptoms despite being on a gluten-free diet. And these symptoms can overlap with the symptoms of disorders of gut-brain interaction, which is the new term. It's really not new. It started in 2016. So we call it DGBI rather than using functional GI disorders, because there's a lot of scientific evidence to support that these disorders are due to alterations in brain-gut axis. And few studies have looked at the IBS prevalence and impact amongst the celiac disease patients in the United States. If you look at the overlap or the coexistence of celiac disease and IBS, the data is greater. It's more supportive in Europe than it is in the United States. In the United States, celiac disease is about 1% of population. The aim of this study was to assess the prevalence and burden of IBS in individuals with celiac disease using a large U.S. population-based data set. So they did cross-sectional online surveys from May 2020 to May 2022. They surveyed over 160,000 individuals, identified celiac disease. Now, this is based on a self-report that the physician gave them that diagnosis. And they used the IBS diagnosis based on the current Rome 4 criteria, which you're probably familiar with, which is the diagnostic criteria for IBS. They conducted a multivariable logistic regression to evaluate predictors of IBS in these patients with celiac disease. The CEDARS group, and I worked with Brennan Spiegel on this years ago, developing this NIH Promise GI symptom scales. And basically what they wanted, what we tried to do is to use GI surveys, and it's with conditional logic for the 8 domains of any symptom in the GI tract. It's basically 8 domains. And you can do this survey in any individual, general population, people with IBS, IBD, scleroderma, anybody with GI symptoms. So it's really a general type of instrument or PRO, patient-reported outcome measure, to use in any individual. So they administered these GI Promise questionnaires, and it assesses symptom severity based on the general population over the past 7 days. And they looked at patients with celiac disease, celiac disease with and without IBS. So there was over 3,000 respondents that reported having celiac disease, and 12% of these met the Rome 4 criteria for IBS. IBS was less common in racial ethnic minorities, more common in those with higher education, income, employment, marital status, smoking, and history of pancreatitis or peptic ulcer disease. And 85% of celiac patients reported having at least one GI symptom in the past week. There were 14 GI symptoms that were more common in patients with celiac disease with coexistent IBS versus celiac disease alone. And that was basically abdominal pain, bloating, gas, regurgitation. The celiac and IBS group had more severe symptoms on these Promise scales. So you can see here, I don't know how easy it is to see, but you can see the dark bar is the celiac patients with IBS, and the light gray bar are celiac patients without IBS. And you can see the prevalence as well as the symptom severity is greater in the coexistent overlap group than in the celiac disease alone. So IBS affects up to 12% of the U.S. population with celiac disease. Now, the general prevalence right now currently, and it depends on what criteria you use, but for Rome 4, it's about 4% of the population. If you use older criteria, it goes to 11%. But IBS was in 12% of celiac patients, which means there is a higher coexistence. And patients who have IBS symptoms will report more frequent and severe symptoms. So it's important to look at this, but the only issue, and I put the limitations here, is you don't know if the patients really are compliant with the treatment. So they're maybe just reporting celiac disease. Do they really have IBS? You can only say someone has IBS with celiac disease if their celiac disease is completely treated, they don't have marsh lesions, but they still have persistent symptoms. It's kind of the same thing with inflammatory bowel disease. You have to have inactive inflammation, but still have persistent symptoms. So that was the only issue. But we do know that a lot of these patients can have an overlapping IBS picture who have celiac disease. So there's some limitations I put on the slide, but I do think it's interesting to really recognize there can be an overlap of IBS and celiac disease. Okay, I'm going to present a couple of studies that we did. This is a study I did with Andrea Shin on an observational study on the risk of ovarian cancer in women with IBS. I actually was thinking about this one day that it's not in any guideline to screen for ovarian cancer with IBS. And we thought this was a good opportunity to take a look at this, which has not been well studied. So as you know, ovarian cancer has a high death to incidence ratio due to late diagnosis, and symptoms can often overlap with non-malignant conditions like IBS. They can present with bloating or altered bowel habits. And, it is a concern. Are we misdiagnosing patients with IBS who really have ovarian cancer, but it's not been studied? So the aim was to assess whether women with a new IBS diagnosis are at a higher risk for developing ovarian cancer and determine if ovarian cancer may be being misdiagnosed as IBS. So this was a retrospective cohort study using Optum's National Claims Database, and we compared ovarian cancer incidence, so they can't have any pre-existing ovarian cancer, in women with and without a new IBS diagnosis. And we looked at IBS at a couple different time points, not at just one time point. And we used a propensity score weighting and Cox models to assess risk. And they also did a sensitivity analysis examining long-term ovarian cancer risk without a 2-year limit. We used 2 years because there's a study that was done, I think it was an IBD, where they looked at people before and after and determined that within 2 years of that diagnosis is where you could consider it's a misdiagnosis, and that you're not going to find a misdiagnosis when you move out of 2 years, and definitely out of 5 years. So that's why we picked 2 years, because we thought if the diagnoses were too far apart, then it wasn't really a misdiagnosis. So there were 79,804 women with IBS and 52,823 without IBS that we included. And there was a higher unadjusted ovarian cancer incidence in the IBS group. So that incidence rate ratio is 1.87 within 2 years. There was no significant difference in ovarian cancer risk within the 2 years, but you can see the p-value is close to 0.05, but it's not, so it's a trend. Then we looked at longer term follow-up, like looking past 2 years, 5 years, and longer, and it showed that there was a significantly increased risk in the IBS group to having ovarian cancer. Now, the ovarian cancer risk increased with age only in women less than 50. Once you get to 50, and 50 is the average age of menopause, you still have an absolute increase in ovarian cancer with the cumulative life risk, but the risk and the ovarian cancer risk was increased by age only in women under the age of 50. So here you can see the Kaplan-Meier curve. In blue is IBS, in red is control. So you can see over that first diagnosis to 2 years, you do see a splitting where you have a higher incidence of ovarian cancer in IBS women versus control women. They're not healthy, but some of them are healthy. But that wasn't statistically significant based on the data we had. But it still suggests that IBS patients may have ovarian cancer at a higher risk than women without IBS, and it definitely occurs longer term. So the key takeaways of this were women with IBS may have a modestly increased risk for ovarian cancer over time, but it is not clear that this association is due to misdiagnosis, as the association is stronger long-term than short-term. Because the ovarian cancer risk is associated with age under the age of 50, you're thinking that maybe there's some hormonal influence, just like there's a hormonal influence in IBS, which is a female predominant disorder. So that's something that hasn't really been explained, but it's something to consider. But future research should explore personalized screening strategies for ovarian cancer in women with IBS, especially those with atypical symptoms or comorbid conditions. And, this is not to make anyone think that we're missing all this ovarian cancer, but I do think it's important, as we know, in women to think about this. They should get gynecologic exams. Even a pelvic ultrasound is non-invasive compared to a lot of invasive studies these patients go through. So I think that's the important part, just to consider it, make sure that they get some type of gynecologic assessment. Okay, this is another study that we did where we want to look at sleep and step count using a wearable device and if it's associated with symptoms in IBS. So as we know that IBS is very common and it involves a bidirectional relationship between the gut and the brain, as well as disturbances in the central nervous system and also the autonomic nervous system, gut microbiota, motility, and visceral hypersensitivity. And you may already know this, but poor sleep is a risk factor for IBS. And many of the patients that we see, particularly those with moderate severe symptoms, don't sleep well. And poor sleep has been shown to be associated with worse GI symptoms the following day and not the other way around. So when I see patients, I always ask about sleep, because if you don't replenish sleep, it makes it harder to have the healing process. And a lot of these patients will have these other types of symptoms. So it is a risk factor. There was a 7-day study using actigraphy that showed that IBS patients slept more but felt less well rested. They had more awakening episodes, which was associated with worse abdominal pain. So no one's really been doing any wearable studies in IBS. They've done it in IBD. As you've seen, this is a recent gastro paper where it can, different wearables, heart rate variability, really heart rate will predict an IBD flare. So we chose Fitbit, and the reason why we chose Fitbit, because first, it's less expensive and it's very popular. Many, many people use it, but it is the one wearable where the sleep information has been validated by polysomnography, which is the gold standard for sleep. It's the only wearable, which I didn't really realize before we started this study, and that's why we chose Fitbit. So the study aims was to compare serial sleep measures captured by Fitbit and daily step count between IBS patients and healthy controls, because we also know that physical exercise can improve IBS symptoms. So we want to investigate the associations between sleep measures captured by the Fitbit and step count with IBS symptoms. We also gave questionnaires for perceived sleep. One was the Pittsburgh sleep scale, which a lot of people use. And then we also used this daily sleep measure, a daily log, where they could capture how well they slept, how many hours they thought they slept, how many awakenings they felt that they had. And then we compared it with the objective sleep data from the Fitbit. And we looked at the relationship between sleep measures and step count. So this is a study design where we gave everybody a wearable for 4 weeks. This is a pilot study. So we had healthy controls and IBS. You can see 24 and 25. We got the PROMIS questionnaires weekly. We looked at the IBS symptoms. It's actually the severity scoring system, the IBSSS, which is a severity instrument we use in IBS. And we looked at anxiety and depression symptoms by the HAD scale. We looked at daily abdominal pain, and then we got a daily sleep measure for the first 2 weeks. So what we found, and you're probably familiar with the sleep stages, I just put a figure here to remind ourselves that you could look at awake time, REM sleep, light sleep, and then deep sleep. And what we found was that it was the REM sleep that was associated with GI symptoms. So if you had more percentage REM sleep, which you can look on your wearable, it was associated with less diarrhea symptoms, less abdominal pain, less gas and bloating. And then increased percent REM sleep. And we looked at percent because everyone has a different amount of sleep. It was associated with lower IBS severity. And increased deep sleep showed a trend for lower diarrhea. So the thought is that it's altering the autonomic nervous system, or a reflection of the autonomic nervous system, which is affected by, which also impacts bowel movement and bowel habits. Now, this is an interesting part of this. So in the orange is the mean hours slept that the participants thought they slept every day for 2 weeks. And in the green is the amount of sleep that they captured on the Fitbit. And what you basically see is that patients will overestimate how many hours of sleep they have compared to the Fitbit. So they think they're sleeping more than they're actually sleeping. And since sleep is important, this is very interesting that would a wearable be helpful to have it, because your perception of what you think you're sleeping is not necessarily accurate using objective measure. So the key takeaways are increased percent REM sleep is associated with lower IBS symptoms, including diarrhea, abdominal pain, and bloating. And there are previous studies that have linked in animal models depriving REM sleep with increased GI transit and visceral pain. And it's thought to be related to the autonomic nervous system, particularly the catecholamine receptors, which, as you know, increases arousal. And individuals tend to overestimate their total sleep duration, and Fitbit represents a more objective way to track sleep data. And a higher proportion of REM sleep tend to be associated with higher step count, although step count wasn't associated with the change in GI symptoms. I think the problem that we had with this, that we took a lot of young people on campus, and many of them, the average step count daily was over 10,000 steps. And, you know, if you guys look at your Apple, you may not be getting the 10,000 steps, maybe 5,000 or so. So we tended to get a very active group of individuals and not as much of a range as we would like. Okay, I thought this was really interesting, is about GLP-1 agonist use is associated with overall improvement of symptoms in patients with IBS, diarrhea, and obesity. And this is based on a national database analysis. So I'm sure everyone here is familiar with GLP-1 agonists, that the FDA has approved them to treat obesity, type 2 diabetes, and cardiovascular risk reduction in diabetic patients. Now, GLP-1 agonists have a lot of different mechanisms of action, both centrally and peripherally. They basically will alter gut-brain signaling. So there are receptors in the hypothalamus, different regions of the brainstem, the nucleus tract solitarius, which is the main center for vagal afferents to go in the brainstem. And what it does, these agents, they'll increase satiety, they'll decrease appetite and food intake. They'll slow gastric emptying and acid secretion. They can increase stomach distension, increase insulin, and decrease glucagon secretion. And they decrease ghrelin, which is the hunger hormone that stimulates hunger. 30% of IBS patients are overweight or obese, and GLP-1s may reduce IBS-related symptoms like pain, urgency, diarrhea. Now, we also know that because of its effect on slowing transit time, particularly more in the upper gut than the lower gut, that a lot of the patients will have nausea or constipation or other types of symptoms. But this study wanted to evaluate the aims in IBS diarrhea patients with obesity who are taking GLP-1 receptor agonists. Now, I want to show you something that I didn't realize in 2008. So I got contacted by this company called Rose Pharma because they conducted this study here that they published that showed that these low doses of an agent that I didn't realize at that time was a GLP-1 analog, and that reduced abdominal pain attacks. And it worked more in IBS-C than IBS diarrhea. So you can see the placebo and the two different doses. These are micrograms. These are very small doses. And it did improve pain relief response and also improve the meaningful time to pain relief. So I worked with this company only to characterize abdominal pain attacks, not realizing this was a GLP-1 back then, because no one talked about it back then. And it was an injectable. And I told them there's no IBS patients that's going to give themselves an injectable to decrease pain. Now, of course, everybody does injectables, and it's probably not as big of a deal as it was back then. So I just wanted to remind people that I actually forgot about that study. So the design of this study is a retrospective cohort study using the TriNet-X database. This is IBS-D patients from 2015 to 2024. The intervention group are these patients on these different GLP-1s. Comparison group is propensity match IBS diarrhea patients that are not on these agents. And the endpoints were to look at functional GI symptoms like pain, bloating, diarrhea, nausea, fecal urgency, and also look at comorbidities. And the analysis was a logistic regression model with an odds ratio and 95% confidence intervals. So they had 8,736 patients with IBS-D and obesity. And you can see there's 929 GLP-1 patients and 909 patients without GLP-1, and mainly more women, and the age was 45. So here I gave the list of what they found was lower odds in the GLP-1 receptor group. So they had less GERD, abdominal pain, bloating, nausea, diarrhea, depression, anxiety, and chronic fatigue syndrome. So it looked outside of the GI tract as well. They didn't find any differences in fecal urgency, fibromyalgia, female genital prolapse, and dyspareunia. So more of the widespread pain and also the more gynecologic disorders. So their key takeaways with the GLP-1 receptor antagonist use that it was associated with lower incidence of GI symptoms and GERD, improved mental outcomes, but no observed benefit for female pelvic disorders or fibromyalgia. So the implication is that GLP-1s may have a broader role in managing IBS diarrhea beyond their metabolic effects. But the next step is really doing these prospective studies. I don't know if anyone has had a patient with IBS who's happened to be on a GLP-1 that have told you that their symptoms are better. I've actually had I actually had a patient recently that told me that, but she was using a very, very low dose. I won't tell you how she got it because she really shouldn't be taking it. But anyways, she was, and her symptoms were better. But I do know that Lilly and other companies are looking at GLP-1s, not just for IBD, but for IBS. But my hypothesis is that you probably have to use a much lower dose than the doses that you use for obesity and diabetes. And then my last one, and I think I'm running out of time, was really to look at face-to-face hypnotherapy with online hypnotherapy using an app, and then against education. So as you know, gut-directed hypnotherapy is this heightened state of focus and awareness. It increases individuals to this post-hypnotic personalized suggestions, trying to change the imagery, and it's been an evidence-based approach to show benefit in IBS. And face-to-face hypnotherapy is effective, but we're really limited by accessibility to therapists and the cost. So they wanted to look at, is online hypnotherapy, is it non-inferior to face-to-face hypnotherapy to reduce abdominal pain? So hypnotherapy is really used to reduce the hyperarousal and also somatic symptoms as well. But I'm going to move ahead because we don't have that much time. So this is a multi-center, 3-arm randomized controlled trial with a non-inferiority design. There's 230 Rome 4 positive IBS patients at 7 Dutch hospitals. You can see they had 3 arms: face-to-face hypnotherapy, online hypnotherapy with a smartphone app, and psychoeducation where they used web modules. It was 12 weeks with a 4-week follow-up. The primary endpoint was a 30% reduction in abdominal pain, which is a FDA-defined endpoint. The non-inferiority means that if it's 10% or less difference, then it's non-inferior. And they looked at secondary endpoints. Basically, what they found is the face-to-face hypnotherapy, this is the abdominal pain responder in the blue, had a higher responder rate than the online hypnotherapy, and it was more than 10% difference. So the online hypnotherapy was inferior for abdominal pain, and they're better than psychoeducation. If you look at overall severity, the online hypnotherapy and the face-to-face hypnotherapy were very comparable. So the patients, they said what therapy they preferred, and 75% preferred face-to-face, but the preference didn't significantly impact the outcomes. And here you can see the adherence, and there was no effect on anxiety or depression. So the key takeaways are online gut-directed hypnotherapy did not meet the non-inferiority criteria for abdominal pain reduction, but both hypnotherapy modalities were superior to psychoeducation for the key symptom endpoints. So it is a online hypnotherapy through an app. It's accessible, scalable, cost-effective. So there is one available that you probably heard of, Nerva. If you ever want to refer a patient to it, it's really more self-management because they're not face-to-face with an individual. But a patient can download the app. What they do is once they go on, they get 1 week for free. Then at 1 week, they charge you $199. It's 15 to 17 minutes per day. They only have to do 5 days or more. That's where they see the benefit. After 6 weeks, you have access to all the modules, which you listen to over and over again for a year. So just as potentially, if you don't have a GI psychologist or you're waiting for one, it is an option for patients. And that's it. Thank you so much for your listening.
Okay, for our next session of abstracts, we're really lucky to have Dr. Ali Rezai, Associate Professor of Medicine and Medical Director of the GI Motility Lab at Cedars-Sinai. Ali.
Thank you so much for hanging in there. So I'm going to talk about a few new tests and new things that are in the neurogastromotility sort of field to kind of make things interesting. So I'll give some background about them because some of them may be new to you. All right, these are my disclosures. All right. So this test has been around for a while, but can't say that it has been picked up clinically extensively as the spirulina gastric emptying breath test is still definitely less common than gastric emptying scintigraphy that we use in the clinical practice on a regular basis. This is FDA approved for gastric emptying. And the way it works is that it works based on the spirulina that is grown in FDA approved labs with C13. So that kind of like seaweed that you can see it on that plate mixed with egg. So you eat that meal and you blow into those tiny tubes, extender tubes, and we send them out. We measure the amount of C13 that is being excreted in the breath. How does that happen? Essentially, that food goes through the stomach, gets out of the stomach, gets absorbed in the small bowel, and then you excrete the C13 CO2 out of the breath. So what comes out is this graph. You can see that the red line is the normal pattern. This is over 240 minutes, 4 hours, that essentially the line starts to go up as the food gets absorbed and then starts to dip down. And that's the normal pattern that we see in gastric emptying breath test. And the blue line is somebody who's normal. So it's above that line and rises and it comes down and it's a normal emptying. However, on the other end, in this case, the blue line is abnormal. This is somebody with gastric emptying delay. The food is not leaving the stomach, hence the C13 is not being absorbed, so we don't see that rise. So what are the advantages of gastric emptying breath tests? Well, it's non-invasive, and also it has no radiation exposure, which is a plus because some of our patients are wary of doing a scintigraphy to because of the radiation risk, even though the risk of radiation is not that high. So it's safe in children, pregnant women, and also breastfeeding women. And also, I don't know about your center. At our center, the wait times for gastric emptying scintigraphy is now several months. This is something that we do in our clinic and within a week or two. So that's quite feasible to do. Also, another advantage is that you can do this with gluten-free option, as opposed to gastric emptying scintigraphy that the toast technically can't be gluten-free. So these are the advantages. So what's new is that there's this presentation that was at DDW and now actually accepted for publication in press in American Journal of Gastro, that they looked to see if in children this works as well. It was a large study. But it was not powered enough for the male subjects. It turned out that male children turned out that they have quite variability. So a larger study is coming along. But, considering that this has no radiation, this is a good option for children. So it's an option that we have now. Next, this was a very interesting study from Mayo Clinic because overlap of irritable bowel syndrome-like symptoms and inflammatory disorders is a hot topic right now. And one of them being a celiac disorder. And I saw Lynn's presentation that a significant proportion of them have a lot of celiac patients have a lot of GI symptoms. And this essentially tried to look at that as well at Mayo Clinic. So what they looked at is that we retrospectively looked at 256 celiac patients that underwent small bowel aspiration, and 39 of them underwent breath testing. So they found that using the cutoff of 10 to the 3 or 1,000 CFU, roughly 50% of them had small intestinal bacterial overgrowth. And breath test was positive in 23% of these cases. There was no association of SIBO and Marsh score in celiac patients. So it does not look like it drives the pathophysiology of celiac disease, rather it causes extra symptoms, GI symptoms for these patients. But interesting enough, they looked at refractory celiac patients, and they saw that essentially almost 80% of them have bacterial overgrowth. And that's not surprising to us because a lot of patients with refractory celiac disorders have significant amount of dysmotility. And whenever you have dysmotility, you have dysbiosis. And that's not necessarily surprising. So the takeaway is that remember, the inflammatory disorders can have a lot of overlapping dysbiosis and dysmotility that can lead to significant amount of symptoms that can be mistaken for that inflammatory disorder. So now in this setting, this can be seen in Crohn's disease, ulcerative colitis, radiation enteritis, celiac disorders. So think about those organic causes that can lead to these symptoms. Now, in this case, it was SIBO, but think about EMO, SIFO, dysynergic defecation, intra-abdominal adhesions, which I see a lot of times being missed, and so forth with the other causes that I've mentioned there that can lead to these symptoms. So think about organic overlap of symptoms that can lead to these disorders. Now, I'm going to talk about body surface gastric mapping in the setting of cannabis hyperemesis syndrome. This is a study that was done by the University of Calgary and also University of Auckland that was done. So what is this? In fact, actually, they have a booth here if you want to go and see how the device looks like. This is essentially a fancy, very advanced version of electrogastrogram that we had before. If you remember electrogastrogram, before it has 3 electrodes, it was not easy to interpret, but now this has 64 electrodes and sits on the belly. And how we do it is that we do half an hour of fasting, then roughly 4 hours after meal to see how the electrical activity of the stomach is ongoing. I'll show you some examples. So the meal is actually much easier than gastric emptying studies. It's quite flexible. You can use Ensure, you can use a Cliff Bar, and they have multiple options. And they have option for gluten-free, they have option dairy-free, which is actually clinically and practically is very important because a lot of patients can't tolerate a lot of specific food items. So this gives us a lot of flexibility to do this test. So what does it show? So it shows multiple sort of data points that you can use to help you what to do. And I don't know if this, yeah, so this works here. So on the y-axis is the number of contractions of the stomach per minute. Remember that our stomachs are contracting every 20 seconds. So 3 per minute is the normal range. But that contraction is relatively weak at the time of fasting, and then it increases in amplitude after you eat. So you can see a significant increment in the amplitude, which is depicted by color. And that continues for roughly 4 hours, but starts to slow down and decrease in intensity after a few hours. And this is a normal pattern, right? So at the beginning, there's some baseline contractions, you eat, and then it gets stronger and slowly just wears off. That's how it is. And the level of scatteredness is also important, especially in tachygastria or autoimmune enteropathy or gastropathy, right? So it gives us multiple data points then. How many, at what level it's contracting. So if it's high, that's tachygastria. It gives you the contraction intensity. So it gives you a good data point of whether it increases or not, and also the scatteredness. And based on this, you can break down patients with stomach symptoms in a way that's, okay, what's going on, right? So this is a classic example of somebody with a neuromuscular disorder, such as autoimmune disorders or diabetic gastroparesis, right? It's all over the place. It's just randomly contracts. It's essentially, think of it like an AFib of the stomach, right? So the way that you manage this one is different. You use pro-motility drugs, and we try to control the underlying autoimmune disorder, right? In this scenario, this is somebody with pylori spasm, right? So you see that actually it's less scattered. It's all over here. It's very tight and continuously kicks in. And you don't see it that wears off. Actually picks up late and it does not wear off. That's when you have gastric outlet obstruction. This is somebody that you will think, okay, so POEMS may work here, or Botox in the pylorus may work here, right? So that's one example. And also when it's weak contractions, we can see some other interventions that we can do. So this study, what they did is that we have a cannabis hyperemesis syndrome, right? So can be differentiated with gastroparesis, because probably you've seen those when they come to the hospital. It's not easy to manage these patients because you throw pro-motility drugs at them, it doesn't work, and you try a lot of things that it doesn't work. And this kind of like confirmed that. It showed that the contractions of the stomach in cannabis-induced hyperemesis actually is quite the same. So whatever cannabis is doing is working on the central side of things in terms of nausea and vomiting. So pro-motility drugs probably is not the way to go in this group of patients. Another thing that they showed in the other study, kind of continuing what Lynn said, and you saw that GLP-1s, how extensive their effect is on the GI tract. They look to see if it affects the electrical activity of the stomach, considering that they cause nausea, vomiting, and also they can slow down the rest of the gut, right? So, and we know that ileal brake and interaction of ileum with the stomach is essentially controlled by GLP-1. So not surprisingly, when they looked at people who are on GLP-1, they saw two very specific things. It decreases the gastric amplitude of contractions, and also it delays kind of the emptying, meaning that it was protracted, right? And remember, the GLP-1s, the original ones that we have, Byetta, the first one, the half-life was 2 hours. The half-life of Ozempic is 137 hours, right? So it has come a long way. And the newer ones that are in the that are coming, it's getting longer and longer and longer. And it's not like the effect just wears off quickly. The effect of GLP-1 on the GI tract in terms of motility lasts weeks. So keep that in mind. And this is in line with that one, which is quite fascinating. One point that I want to mention is that GLP-1s affected GI motility significantly, but GIP is very different. GIP essentially doesn't affect the motility as much. And that's why, for example, we see in the most recent clinical trial, which was tirzepatide versus semaglutide, essentially showing that tirzepatide has much less GI side effects. So the future, hopefully, when we have these combo drugs for obesity, the GI side effects would be less, which is quite exciting. Next, I wanted to talk about this because there is unfortunately little activity in terms of clinical trials in IBS. The last approved drug was for IBS diarrhea was 10 years ago, and literally there are 0 phase 3 trials are ongoing with IBS, which is a little bit disappointing, but this may give us a way out with combination therapies to see if IBS patients can benefit with lower dose medications, but a combination of medications. Where is this coming from? We know that a microbiome is important in IBS diarrhea patients, and a subgroup of patients, when we treat a microbiome, they get better. Now, these can be directed by the H2 producer or hydrogen sulfide producing bacteria. These are classically E. coli, Fusobacterium, and also Klebsiella. And one important thing about these bacteria is that they're very active in biofilm. And poorly absorbable antibiotics that we use, such as rifaximin, they do not penetrate into biofilm really well. So the idea is that if we use a mucolytic along with poorly absorbable antibiotics, does it get better for patients with IBS patients? So there is this non-inferiority test that compared rifaximin 550 milligram TID versus rifaximin 200 milligram TID with placebo, or rifaximin low dose 200 milligram with NAC to see if it's non-inferior, and this is the way to go to move on to a bigger trial. Endpoints were very typical, with improvement in stool frequency and also improvement of abdominal pain, essentially what FDA recommends. There was interesting enough, in terms of stool frequency, it worked a little bit better with rifaximin 200 milligram 3 times daily and NAC, but bottom line is that this was a non-inferiority trial. The most important thing is that it was not necessarily different from the rifaximin 550 milligram TID, and abdominal pain was similar. This was a small study with 45 subjects, so we can't jump ahead in terms of conclusions, and we'll see what happens with the larger studies, and a phase 2b is being planned starting this fall. And in terms of adverse events, not surprisingly, there was not much in terms of severe or serious adverse events. This is another study from our group, which is, again, underlines the effect and profound effects that diets can have on our gut and our gut microbiome. A little bit background about elemental diets. Every now and then we hear about them. They have been around actually for more than 50 years, originally developed by NASA because they didn't want astronauts to go up there to poop much, because it's really hard to poop with no gravity. And when you have elemental diet, the excretion is less. So that was the idea. But obviously then it got into medical field, and it took off. And essentially they're complete and near complete nutritional sources. The modern elemental diets are quite different from what they used to be 50 years ago. Now, the source of protein has to be free amino acids and no peptides. And by that means that these are allergen-free. By definition, there is no allergen in these diets. And carbohydrates are short-chain carbohydrates, usually maltodextrin or glucose. And also lipids, now the modern ones have MCT oil rather than LCT oil, because LCT oils are pro-inflammatory. So because of this phenomenon, they have multiple benefits, going from being completely allergen-free. So they are used in a lot of type 2 related disorders, including EOE and EGIT. They get absorbed at the beginning of the small bowel, so it gives the body a pseudo-hibernation, pseudo-fasting effect, and that's why we use it in fistula, we use it in SIBO, and they have low fat content. That's why they're used in chronic pancreatitis, especially in Japan. That's a common way to decrease the amount of pain in these patients. And they have no food additives. We talked about microplastics and all that, and food additives and how bad they are. And also the microbiome modulation, and the fact that a lot of times patients that we have, especially with the restrictive diets that they're on, they have some sort of clinical and subclinical micro or macronutrient deficiencies that we are not picking up. And these are complete diets, and it fills up the tank, if you will, when you treat them with these medications. And also they have significant amount of glutamine, and that has been helping with the improvement in mucosal permeability. Okay, so why don't we use them all the time? The reason is that elemental diets taste like sewage water. And because the free amino acids are very sulfury. So when you drink them, it's just, I don't know if you've tried them, it's not good. So that's why in the previous trials, and the ones actually we did, it's some of them, the dropout rate is almost 40%. Now, the technology has improved, with engineering has improved. Now there are palatable elemental diets that are now available. And this is a paper that actually, the data we presented, but the paper is already published in CGH. These are the 30 subjects that we followed for 7 days. And then we treated these patients with EMO and SIBO for 14 days with exclusive palatable elemental diet. And we followed them again after they restarted their regular diet, and we did all the biological sample testing as well. And we did daily diary testing, and we didn't stop there. We asked them to take a picture of their poop and to analyze exactly what it was, the Bristol stool scale, based on the AI-assisted analysis. And bottom line, what we saw is that, first of all, out of 30, all 30 subjects could finish 14 days of exclusive elemental diet, so 100% tolerance. 73% improved their breath test, 83% had symptom relief, and also we showed that the microbiome improved in terms of drop in M. smithii and Fusobacterium and no severe adverse events. And this is the breath test. I'm just going to go quickly over that. And you can see that this is the hydrogen production before the elemental diet, the solid red line. And you can see that after the elemental diet, it switched from a small bowel pattern to a colonic pattern. Essentially, now they have normal colonic fermentation at 100 and 120 minutes. And methane levels at every single point, they dropped. And this is the daily methane levels that they significantly dropped after the elemental diet, so which was quite exciting. Sensation of incomplete evacuation actually decreased significantly about 1 week into the elemental diet. And you can see that the complete bowel movements was 40%, and it dropped to 68% and remained at that level even after reintroduction of food, which was interesting because we were expecting to see a big dip right away after, but that did not happen. And Bristol stool scale, based on AI imaging on the stools, it actually improved, showed significant improvement. But I think what was very interesting in this study was this, that the symptom improvement was persistent. We followed these patients for 2 weeks after elemental diet because I expected they dramatically go back where they were after reintroduction of regular diet. If I knew this would happen, I would have followed them for way more. So yellow or orange is the improvement of the symptoms in terms of percentage from the baseline right after elemental diet. And green is actually improvement of the same symptom based on average daily symptoms 2 weeks after they reintroduced diet. And they kept, interesting enough, in most of the cases, they kept getting better. Pain got better, discomfort got better, bloating remained the same, distension remained the same, flatulence maybe took a backward effect. Fatigue significantly improved, urgency kept actually getting better, constipation got better, brain fog actually better. So this got us by quite a bit of a surprise, and just telling you that how effective diets can be, and more importantly, they can have lasting effects even though they go back to where the years used to be. So we're planning to do a longer study to see what's going on here, but I found this very interesting. So that was my last slide. Sorry, I went over for a couple of minutes, but I'll ask Dr. Lin to come by. Oh, okay.
Okay, for our last and maybe best state-of-the-art talk, we've got Lin Chang coming back up. And this is going to be kind of a high-level explication of current knowledge on the multifactorial pathophysiology of disorders of the brain-gut interaction. So maybe not the standard, these drugs or this diet, but kind of a higher level thought piece. So, Lin.
Yeah, I thought it was supposed to be a pathophysiology talk. I hope you're not disappointed we're not going to talk about treatment, but I'm happy to talk about anything you want to talk about during the Q&A. So again, these are my disclosures and this is the objectives. What is really important, I feel, is to understand the pathophysiology of these disorders. And the reason why it's so important, not only to develop new therapies, but you have to explain to the patient why they're having symptoms when all their tests are negative. And if it's not explained well, that makes sense to them, they're going to keep wanting more tests. So it's really important. And once you explain to them based on the set of the symptoms they have, then they understand why they're not getting another CAT scan or another endoscopy. So I want to describe the brain-gut pathways relevant to these disorders of gut-brain interaction, and I'm going to focus more on IBS, which is the area I know well, and it's really more of where the literature is. Some in functional dyspepsia, but really most of the studies are done in IBS. So I'm going to review the central and the peripheral mechanisms that are related to IBS pathophysiology and the phenotypic features of this condition. And I'm going to discuss the implications of targeting the brain-gut axis when you treat patients with IBS. So as I mentioned earlier today, the new terminology is disorders of gut-brain interaction, and this is defined as a group of disorders that are characterized by GI symptoms that are related to any combination of the following, which is a motility disturbance, visceral hypersensitivity, altered mucosa and immune function, altered gut microbiota, and altered central nervous system processing of visceral stimulation or input to the brain. So it's definitely multifactorial, and some of these will be very common in individuals, and others, it may just be personalized to them. But you can see there's genetic early environment type of predisposition, infection, and there's different triggers. And this will take a long time to go over. But what I try to figure out in the patient are what are the factors that increase that patient's risk to getting IBS or DGBI, and what are the triggers of the symptom flares, because that's really the important parts. And that's the part that I hone in when I do a history. So this is a pretty simplistic model of the brain-gut axis. And so I just wanted to use that. So what you can see, and I'm sorry I don't have the laser, I don't know which one, I can point to one of these. So if you have any stimulations, distension, contractions of the GI tract, that information is transmitted through spinal afferent and vagal afferents, if it's in the upper gut, to the dorsal horn neurons of the spinal cord. And then that ascends, it crosses over, ascends, projects to the brainstem that you can see there in the center, and to regions in the brain. A lot of that information, as you know, we don't even perceive what's going on in our guts, and that's termed interoception. Our brain is assessing what's going on in our inside of our body, and it's regulating it. And so hunger we may sense, but a lot of other changes that are going on after your meal, you're not even consciously perceiving it. But in some individuals, when they get that information set to the brain, they'll perceive it as a threat or as a symptom, not as something normal, if they can perceive it. And that information is modulated, and there's outflow from the brain back to the body and to the gut. And the two main outflow is pain inhibitory, descending pain inhibitory pathways, and the autonomic nervous system. So the pathways, the PAG that you see there is the periaqueductal gray. That's the main control center for descending pain facilitation pathways and descending pain inhibitory pathways. And we have both. And you can understand why we would have both. Sometimes it's protective to have more pain facilitation, but we really want pain inhibition when we get exposed to something nociceptive. Those projections then go down to the dorsal horn neurons, and it'll reduce the excitability of those neurons. So if you have descending pain inhibitory pathways, it's going to reduce the excitation of those neurons that are getting stimulated through from the gut or from other parts of our body. So if we get exposed to a threat, we're going to activate our descending pain inhibitory pathways. What happens in IBS or these patients with pain is that'll be threatening, and they will modulate that information to not engage in descending pain inhibitory pathways. Because if you really think about it, if you're having pain, you don't know what it's due to, and you're thinking, was it something I ate? Is it going to be a bad day? You're going to be very hyper attentive to that part of your body, be very hypervigilant, which will amplify the intensity of those sensations, and it will not engage the descending pain inhibitory pathways because probably the body thinks that it's protecting itself by being very aware of what's going on in the body when they don't have control over that. Now we have moved more to brain-gut microbiome access, and the microbiome is very interesting, of course, and there's not a lot that we don't know about it. But the microbiome the microbes can make metabolites that can get absorbed, go into the systemic system, and some of them can cross the blood-brain barrier, some of them don't. The microbes can also stimulate enterochromaffin cells, which can then synapse with vagal afferent fibers, and that can go up to the brain as well. There's also communication through different neural pathways, through different hormonal pathways, and so this is the way there's a bidirectional communication between the brain and the microbiome. The brain can also affect and change the microbiome. It's really thought that it's more through the noradrenergic, the sympathetic nervous system. So there's both ways that we can change the microbiome and the way the gut is being signaled. And it's not just involving GI symptoms, it's involving other parts of the body, but it can affect mood. There's some animal studies about probiotics affecting depression, but we'll see if those ever really pan out in human studies. So I just wanted to give you a simple figure of visceral hypersensitivity. So on the x-axis is stimulus intensity. On the y-axis is the intensity of that perception. So what you can see in healthy subjects in the blue is this stimulus response curve. So as you have a higher stimulus to the right, then you'll have the individuals reporting some kind of sensation. And then if it goes even higher, they consider discomfort or pain. If you see patients with these abdominal pain disorders, it's a leftward shift. These patients are now going to respond in the yellow line at a lower stimulus intensity. They're going to perceive it where healthy people never perceived it. Or if it's actually nociceptive and painful, healthy individuals say, well, that's painful. But a hypersensitive patient will say that's more painful. So that's called hyperalgesia, when you have a painful stimulus that you consider more painful, and allodynia means it's a non-painful stimulus that you consider very uncomfortable or painful. And those are two different entities in pain, and IBS patients can have both, or patients with chronic pain disorders. So our patients are just having a leftward shift. Now, what I think is really important is what symptoms are associated with rectal hypersensitivity. And the way we do hypersensitivity in the bowel is do a balloon distension. And I did a lot of these studies earlier in my career. This was done in Sweden, and they inflated a rectal balloon, and they looked at healthy people. And if you were 2 standard deviations away from healthy, you are considered rectal hypersensitive. Where there are IBS patients, they won't have rectal hypersensitivity. They may have pain, but they don't have rectal hypersensitivity, so we don't use it as a diagnostic test. But you can see here in the orange, the individuals that had rectal hypersensitivity versus the IBS patients that had normal sensitivity. And they looked at all the different symptoms, and they said which symptoms are independently associated with having rectal hypersensitivity. And there's 2. It's pain, of course, and bloating. So one thing to remember about bloating, of course, it can be due to foods, it can be due to constipation, but one thing that it could be due to, if you've already dealt with both of those aspects or other aspects, like Ali studies a lot of small intestinal bacterial overgrowth, is that bloating can be a manifestation of visceral hypersensitivity. So remember that pain, discomfort, and bloating are highly correlated if you look at clinical trials in IBS. So just think about bloating as potentially due as a reflection, a manifestation of rectal or visceral hypersensitivity. So I want to talk about bottom up, and then I'll talk about top down. So we have this whole, what is now called the gut connectome, where you have different epithelial and deeper cells, the immune system, enteric neurons, and then you have the luminal contents like the microbiome, and the microbiome can also be adherent to the lining of the gut. Food, antigens, bile acids, all of those work in concert. They call it the gut connectome, but that information gets signaled up to the brain. So I think a good model to talk about this is the post-infection IBS. And we changed the name from post-infectious to post-infection because it's not really infectious per se. So we know that this is one of the most common or highly high risk factors for IBS is having an infection and then not having IBS symptoms in the past and now getting IBS symptoms. There's a lot of systematic reviews on this. But in an acute infection, as you know, there's going to be increased intestinal permeability, some inflammatory, a heightened immune system, bile acid malabsorption, dysbiosis, and that information is going to get signaled through these afferent nerves to the brain. Now, this is going to clear, but only a certain percentage of people are still going to get IBS, even though the infection's cleared. Who are those people? There's some people with a genetic predisposition, having a severe GI infection, being female, and having psychological distress at the time of the infection. So even after the infection clears, there's still some residual dysregulation at the gut level. There's increased intestinal permeability, not in everybody. There's an enhanced immune responsiveness. And in those patients who have stress or psychological symptoms, they can be more prone to that. And it's probably because they don't have the probably healthy descending input back down to the gut to stabilize it. There's a lot of other neural mechanisms of visceral hypersensitivity where immune cells or even the microbes can secrete metabolites, and you can act on these spinal or vagal afferent nerves. And there's a lot of different receptors that transmit nociceptive information to the brain and at different levels within the bowel wall. One thing that I want to draw attention to is mast cells. So mast cell, as you know, is involved in many conditions like asthma, atopic conditions, but it has been a focus of attention in IBS and to some extent functional dyspepsia. So there's evidence that it's not so much the number of mast cells that you count, it's the number of mast cells near sensory nerves that is correlated with abdominal pain. So mast cells, when they degranulate, they secrete a lot of mediators like tryptase, proteases, histamine, and it can act on these receptors of nerves, get them excitable, change motility, secretion, sensitivity. And they did this study where they took biopsies from the colon, they got the supernatant where they soaked it in, this fluid, and then they gave it to an animal and they measured the afferent nerve discharge, and they found that in IBS, that there were local mediators that were stimulating, exciting these nerves compared to healthy individuals or the control of saline. There's a really interesting study that I think about a lot that was published in Nature by the Leuven group. So a lot of times I know patients are thinking they have mast cell activation syndrome, I have a mast cell disorder, or this is a food allergy. But what study this showed, which I thought was really interesting, is they took typical food antigens that people don't tolerate, soy, wheat, gluten, milk, histamine, and they injected in the lining of the rectal mucosa. I think they really should have done the duodenum, but it was easier to do it without sedation. They put in the rectum and they measured, you can see in A, the wheel response. And the top is the healthy volunteers, which you don't see much of anything, except they had a positive control of histamine. But you can see in the IBS, they had much more of a wheel response to these food antigens. And then what they did is they looked at the proximity of the mast cells that were close to these nerve fibers. And they found that in IBS, they had smaller distance of the mast cell to the nerves that you can see over here. So IBS patients had that, and that was correlated to abdominal pain. Then they measured IgE in the tissue and found that the IgE levels that, are linked to mast cell function were elevated in IBS, and that was also linked to abdominal pain. So it was really interesting to think that women may not have a whole mast cell activation syndrome, but that there's certain foods that can give you a local mast cell IgE response locally. That can induce changes in gut function and symptoms. So that's something that I think about. I think it's really, really interesting. And then I also was mentioning that these enterochromaffin cells that make tryptophan and serotonin and a lot of different mediators and hormones, they've actually found that they have neural properties. This is very famous work, and they call it a neuropod. So these epithelial cells actually start having features of a nerve, and they can communicate with a synapse to these vagal, and there's some evidence that maybe even spinal afferents to the brain. So that's another way of signaling. Now, I want to talk about a little bit more about the brain, and not to make this complicated, but there's different networks that we have in our brain. The default, which you see here right in the middle, okay, the default mode is what we're sitting at when we're not doing anything. And that means that it's just processing thoughts and even planning what you're going to do in the future. So let's say we get these signals that from the brain, from the gut here. And when they go up to the brain, the first part of the brain that it hits is the sensory motor network. That's where sensations come in. And then that information then gets projected to the salience network. The salience network, part of the brain, is what the part of our brain that we determine if we feel something in the body, is that normal? Is that a threat? And we try to determine the importance of it. If we find that something that we're feeling is threatening, we switch out of the default mode and we go into the central executive network where it now is thinking about, this is what I'm feeling. What am I going to do in response to it? And if it's a real threat, it gets projected to the emotional arousal network. We can get a lot of more of the emotions, distress from it. And then that emotional arousal network then project to the central autonomic network. And the central autonomic network is the main control for the autonomic nervous system back to the body. And there's a lot of brain imaging studies that have shown changes in IBS, and I was going to show you one that I think is more simple. So they divided the IBS into hypersensitive by rectal balloon distension that I mentioned earlier, and the normal sensitive IBS compared to healthy controls. They did rectal distension, and then they measured blood oxygenation or activation or deactivation. So what you can see in the hypersensitive group is that they had increased signals and activation of regions of the brain that are part of the sensory motor and also the salience and other networks that are associated with increased sensitivity to or perception to a stimulus. The blue that you see in the normal sense of the healthy controls is the perigenial anterior cingulate cortex, and that's linked to descending pain inhibitory pathways that I mentioned earlier. That's really the response you want. The hypersensitive IBS patients did not have that. So it suggests that they did have increased activation from that was sensory in the brain, and they were not activating the descending pain inhibitory pathways in these hypersensitive groups. So I also wanted to talk about the factors that increase the risk of these pain disorders, like you can see female sex, gastroenterolitis, a lot of psychological disorders, and then also extraintestinal symptoms. But I want to bring your attention to persistence. Having psychological disorders or stress is what maintains symptoms, and we're always trying to reduce these symptoms. So to always keep in mind that even though we're not psychiatrists, psychologists, it's really important to patients to address that, because that is the one key factor that you want to intervene on, because it will help to reduce the maintenance of symptoms. The reason why I want to bring this up is I think that we all think about stress, which we all go through, and some of it's good and some of it's not so good. But stress, people tend to think, oh, this is all about psychological symptoms, about mood, anxiety, depression. But stress effects, they have neurologic and neurotransmitter hormonal pathways that stress can actually change gut function. It's not something that we're imagining. And a lot of it is mediated through the corticotropin releasing factor, which, as you remember, is secreted from the hypothalamus. It stimulates the pituitary gland to make ACTH and then stimulate the adrenal gland to make cortisol. But there are CRF pathways that have nothing to do with cortisol. And what they do in the gut, and Yvette Taché did a lot of this work at UCLA, is in the upper gut, they slow gastric emptying, makes people vomit, and in the lower gut, it speeds it. So you go to the bathroom frequently. But it's been shown that stress can increase intestinal permeability. It enhances the immune system in the gut. It can change the contractility of the gut, and it can lower pain. And it's called stress-induced visceral hyperalgesia or hypersensitivity. That's the term that's used in animal and human models. So just remember that stress can have direct effects to the GI tract. This I put together to think that some patients have more peripheral influences that are driving their symptoms, and there's some patients that are less of them that have more of a centrally dysregulated phenotype. And in those individuals, they tend to have more comorbidity with non-GI disorders like fibromyalgia, migraine, or psychological disorders. And you want to think about the treatments that if you want to use the term more gut than brain, you may use more peripheral acting agents. If they're more brain than gut, you want to use centrally acting therapies. That could be neuromodulators, or it could be brain gut behavior therapies. So that's how you may think of these individuals that you see in clinic. And then we look at the brain-gut axis and we target it by different ways. And I showed this slide on the behavioral therapy, like cognitive behavioral therapy, gut-directed hypnotherapy, mindfulness-based stress reduction. And then on the right is from the AGA guidelines, where we have different treatments that are peripherally acting. Some of them are centrally and peripherally acting that can target different aspects of the brain-gut axis. So I want to finish and conclude that IBS and other functional GI disorders are currently referred to as disorders of gut-brain interaction. These disorders have a multifactorial pathophysiology, and visceral hypersensitivity and pain-related DGBI is due to peripheral and central sensitizations of visceral sensory pathways. Peripheral mechanisms include alterations in the enteric nervous system, neuroimmune activation, intestinal permeability, microbiome, metabolites, and visceral mechanosensitivity. And DGBI have increased ascending input to the brain regions that process this information, modulate that information, and that there's reduced engagement of descending pain inhibitory pathways. And DGBI treatments can target either central and or peripheral mechanisms to lead to reduced symptoms with time. So I hope that was informative, and thank you for staying and for your attention.
Okay, while Ali is coming up, I'll just remind everybody that the liver meetings are December 13th and 14th in Dana Point at the Ritz. So if you haven't signed up, please sign up. This meeting will be back here next year, June 6th and 7th. So same weekend. And we're all looking forward to seeing you there. In terms of questions now, please come up and ask your questions. I'll just ask Lynn one about we always worry in an IBS patient, how much workup do we do, especially less than 50. We want to do less. We want to reassure them that's part of the therapeutic process, and not spending, too much money or getting people involved in test after test. This association with ovarian cancer seems pretty weak to me, 1.5, 1.8 with, near intervals that are crossing over except for, with time, I guess, which makes it even weaker to me. And I wonder, there's so many confounders in this kind of a study where you're using a database to look at it. For instance, people with IBS see the doctor more, they get more tests, they demand more tests. So then maybe there's diagnostic bias and they're just, being found with ovarian cancer earlier. And it's such a small signal. I mean, definitely don't want to miss one if we can avoid that, but I'm not sure it changes our practice. Any thoughts?
Yeah, it was just that no one's actually even looked at it, which is kind of shocking to me that you wouldn't even look at other pelvic conditions, right? So I think that's the important thing. A lot of the individuals without IBS did have a lot of other comorbidities. It was just trying to balance by propensity score. But I agree with you. I think my only point on this is it should cross your mind that all individuals, especially when you have abdominal or lower abdominal symptoms, that a woman should remember to get pelvic exam. I mean, that's really it's not to do all these invasive tests. It's so that I don't know if it really crosses people's mind, which they should.
Point taken.
Question for Dr. Razai. Thank you so much. Exciting results you presented. One question about the allometry, and then one question about your elemental kind of palatable, diet bar. So for the allometry, the gold standard for gastric emptying, of course, being scintigraphy, we know is very, flawed, right? Because so many of our functional dyspepsia patients are not going to have a positive scintigraphy. And so, I'm really curious, I don't know if you have the data for this or not, but, the use for differentiating cannabis hyperemesis syndrome, right? Versus gastroparesis, very compelling. I think that was really well done, well thought out study. Just curious, in your mind, do you see and do you know data that's maybe unpublished, whether or not this is going to be more sensitive in diagnosing kind of this spectrum of patients with underlying either autoimmune kind of type gastroparesis or just some minor neuromuscular, issues not detected before on scintigraphy? And do you see that being, because it's such a better physiologic data that we're getting, do you see that helping us to define those phenotypes better and managing those patients better?
Absolutely. I think that's the advantage of this. I don't think this is a competitor for gastric scintigraphy. They just answer different questions. If you think about it, this is similar to echocardiogram versus a Zio patch, right? So they answer completely different questions. Yes, there are some disorders that they have overlapping issues. This essentially will tell us a little bit what is the electrical activity and whether there is some sort of arrhythmia in the stomach is ongoing, and eventually whether there is specific treatments for this motility and dysrhythmia of the stomach, which I think is very promising. Because, I mean, needless to say, that the experience with gastric emptying all throughout the years has been a little bit disappointing in terms of guiding treatment and response to therapy in clinical trials. And hopefully, maybe with this or combination of this with gastric emptying, we'll pick up more subtle disorders and also better outcomes in terms of what medication would work better in who, rather than trying what medication in all gastroparesis patients.
Right. Thank you. The question about the elemental diet, I don't know, there's a lot more data forthcoming, obviously, later as your study continues. Just wondering, is the current elemental bar that you're using in your studies, is that proprietary or is it something that is available already on the market, things that can be utilized?
It's not a bar and it's available. It's essentially food, can be bought online. It's a powder, so you just mix it with water. Actually, interesting enough, elemental diets can be made into bars because you need something to mix them together and you're not allowed to. So they always come in pre-mixed form. Whether you look at, for example, the classic elemental diets like Vivonex, it comes in a powder form or pre-made form that we use it in the hospitals. This one was Mbiota that is mixed with water, and it only comes in powder form.
Great, thank you. Yeah.
Just a few comments. Gilda Radner's ovarian cancer was diagnosed by her gastroenterologist. She had seen her gynecologist and missed it. And he's the one who ordered a CA-125. And so after that, after getting a lot of advice in People magazine on how to manage patients, I started getting CA-125s, but it was restricted to women. You talk to your women patients and you say, how long have you had your symptoms? And they'll say, well, I can remember junior high. All of a sudden, I think if you have a woman who's 40, 50 years old, who has no history of IBS, no post-infection, and you factor out the postmenopausal constipation, and they have new onset GI symptoms, I don't think it hurts to get a CA-125. Yeah. I mean, it's just, I know it's not a great test. It's not a perfect test. It's not a great screening test. But as a gastroenterologist, I think that's an easy thing to do. And so I picked up a couple of ovarian cancers throughout the years just by doing that. Yeah, and the second thing about the GLPs, I had a patient I saw a couple of weeks ago who came in and she has classic bile acid diarrhea after cholecystectomy. She's overweight. And she brings an article from Lancet and she says, read this. And it's the successful use of liraglutide in the treatment of bile acid diarrhea. And it was impressive. So when you talk about the IBS diarrhea patients, and in that group of patients, we're dealing with bile acid malabsorption to a group of people that are, beyond TI resection, beyond post-cholecystectomy. There's other people. I think that might be the mechanism. So she says, God, if I don't have to take this Cholestid 2 times a day, and I need to lose 40 pounds, can you write me a prescription for this liraglutide? I said, sure, let's see if the insurance company will buy it. But I don't know, it made good sense to me.
Well, GLP-1, as I showed you in that figure, has many different actions. So it's probably not just one. I mean, it's definitely going to slow transit. So even if you have bile acid, because bile acid, it stimulates 5-HT and increases promotility. So it's probably counteracting that. But I think that the interesting part about GLP-1 is because it's working on the interoceptive pathways, is it reducing the perception of symptoms, not just motility. that can help patients with these sensory symptoms. That we'll see what happens, but it's looking like, first of all, a lot of these companies have a lot of money, so I think they're looking at other indications, but we'll find out. I just think it might be the dose that's different. But what's interesting about your first comment is my colleagues in the UK, they often order CA 125. Like they standard. I haven't seen a study on that in this patient population, but yeah, that's what they do in Europe.
Dr.
Dr. Matt?
Rosaya, a quick question about the use of the small universe of patients that had a truncal vagotomy with or without gastric resections, you know, in terms of electrical activity. Have you had a chance to look at that, or anyone else?
No, absolutely. At the vagotomy patients, there was actually a study that the elementary team has done, was not presented at DDW. These patients classically present the way that the gastric outlet obstruction patients that I showed you. So interesting enough, when you feed them, the increment in the amplitude of contraction of the stomach picks up a little bit slower. For us, it will pick up like within minutes. In those, picks up about 30, 45 minutes late. Then it just drags on and progresses for a longer period. Now, obviously, vagus nerve does a lot of things to the stomach, but one of the issues when you have a vagotomy, you have pylorospasm, right? So that's one issue that happens, and also the contractions of the stomach is affected. So yes, this test does pick up vagal nerve injury associated electrical activity disturbances of the stomach. Very interesting.
Hi, Matt Freineman from Woodland Hills. Question, I was at this conference, I think, about 7, 8 years ago, and I think Dr. Pimentel gave a talk about the anti-vinculin antibody with regard to being a blood test to diagnose IBS. What happened to that research?
Yeah, well, I mean, that test is interesting. It is ongoing. In fact, actually, one of the ways that we want to see is that if, for example, those antibodies is taken out of the blood, do patients do better? And via multiple modalities that we can take antibodies out. Yeah, so that's an active field of research that is still ongoing. Has it translated into, okay, so you have a positive antivinculin, now how do I treat you specifically? Not yet. That is in the animal stage.
Okay, thank you both very much. We'll see you all next year.